which are helpful, mallets or a spike pusher, they're useful to push the fragment closer to the nail. However, a flip fragment cannot be reversed even if you try to manipulate with the K-wire in a close way. So very often, if you want to rotate, you have to do a formal open reduction. Various hooks can be useful to some extent in realigning these comminuted fragments. Unicortical diaphyseal or bicortical metaphyseal, in those situations, you can use a shank spin, but I doubt whether they are really helpful in rotating the fragment in a closed method. Double butterfly, where you see a segment which is split into two, has here a large reverse fragment, and once you nail it, there will be a large bone gap, and that will have tremendous strain on the bare part of the nail, and that will have a worse outcome. And in those situations, the union rate normally of a femur is about, in a diaphyseal area, is about 98%. So here in the presence of comminution, where the fragments have displaced, they are away from the nail, reduces by about 6 to 8%. In this situation, where even after alignment, even after maintaining the axis, having locked proximal and distal fragment, you have a situation where it is reversed. The about 2 inches of the nail is bare. There is no bone around. We are in a dilemma whether to bone graft, whether to do an encerclage, or do percutaneous methods or wiring. So even if you try to rotate, it doesn't budge. And once you have achieved a stable reduction, the reverse morphology, here the endosteum is turned on the opposite side by almost 180 degrees. So what do we expect? The close reaming products on the medial side, you can see at 2 months, they have thrown some new bone, and at 5 months, and then at 8 months, that fragment has completely incorporated. So that is usually the fate of a reverse fragment when you have a younger individual where you have achieved a good construct stability. So these butterfly fragment, they need not be opened, they need not be rotated, they need not be wired, provided they are very close to the nail. So that is the healing at about 7 to 9 months. This is the 9 months actually. Now, another situation, particularly when you have in the diaphysis, you have a situation, larger the size, after nailing, you can see there is a rotated butterfly fragment, but one end is still in contact with the distal fragment. The other one is separated only by about 0.5 centimeter, and that fragment is still very close to the nail. So well-aligned, long, thick, static nail will give a good construct stability. No graft was done. And you can see at about 3 months, there is a new bone formation at both the ends of this rotated fragment. And subsequently, at about 8 months or 9 months, that you can see a healing of both the ends of this butterfly to the proximal and distal fragment. And on the opposite side, there is a good callus and incorporation of the another butterfly, which was on the posteromedial side. Weak construct. When the nail size is thin, there is a large butterfly which is separated by almost 1 centimeter here. So this fragment, this butterfly fragment, is separated by more than 1 centimeter from the nail. So the strain on the nail, the stresses, the bending stresses at the fracture site are tremendous in the situation where that fragment has separated significantly and is away from the nail. So there is a continuous fragment motion which does not allow the callus to form. There is a poor contact at both the ends, the proximal and distal end, and that leads to breakage of the distal screws first, and then subsequently the nail is going to break. So when you have a situation like this, the more than a centimeter separation of that butterfly fragment, the incidence of non-union or breakage of implant increases to almost 21%. So this was exchange nail and grafting. The fragment was left alone like that. And that is at about 6 months, and that completely healed in a year's time. That is his range of movement. Additional cerclage, when do we use it? Very rarely, particularly when you have a very large fragment, more than 8 centimeter. There is also a study which suggests if the fragment is larger, the chances of non-union are very high. And you must address this by a cerclage wire or a cortical screw by opening and reversing or realigning the fragment to the nail. Here, the reduction was difficult, and hence we had to open reduce it. And that is the reason that butterfly, we have used a cerclage wire. However, the results have been almost the same. It also healed in an expected time. That is his function. When you are at the junctional zone, the nail usually following a non-union, it tends to translate medially, leading a fracture malalignment. Non-union with a broken nail in a junctional zone. Here, that butterfly fragment has healed at one end. However, there is a non-union at the distal side, and that butterfly fragment is not contributing to the healing or new bone formation. Again, here, the mechanics are poor. The distal fragment is small, and the construct stability is poor because of the wide medullary canal. So here, it needs a dual implant where don't try to manipulate that butterfly fragment. Supracondylar nail, after removing the previous implant, adding a derotation plate, which a small plate where you can put 3.5 screws anterior and posterior to the nail, will give you a good bicortical hold, and just 3 or 4 screws across are adequate to give a stability in this situation, where at about a year and about 9 months, almost 2 years here, you can see that is a good healing of the non-union, and that is the patient's function. When we have a situation where that fragment is split into two, usually that one fragment tends to heal or take a longer time. Here, it took almost 2 years to heal, but before that, this has to be exchanged, as that fragment was not contributing and there was a delayed response. Hence, a grafting and an exchange nail was done here. The construct was changed, and that healed in an expected time. Even in a segmental fracture, we may have a combination, we may have a butterfly, but if you do a close nailing and realign them, most of them will fall back in position and they do not need any separate treatment. We have situations where the fragment has rotated significantly. So in the presence, even if you do a bone graft, you can see that fragment is totally separated from proximal and distal fragment. Here, even if you do a bone graft, that graft in the presence of instability, the nail is loose in the distal canal, that graft will be resolved, and we have to change to a different composition of the construct, wherein you have to use a bridge plate, and that solved the problem of healing. The advantage of plating is direct visualization to assess the fragment reduction and achieve a primary stability with the help of a plate, interfrag screws, like that. The disadvantage is it is associated with periosteal stripping, increased blood loss, and increased operating room time. To conclude, after nailing, most of these fragments will realign and they do not need any separate fixation. Provided the length, rotation, and axial alignment is addressed, these fragments should be left alone. Aim of a stable construct should be a thicker nail and more number of screws in proximal and distal fragment. If unstable, you can use if there is a significant instability, or you're not able to pass a thicker nail, or the configuration of the fracture is such where you cannot use a number of screws proximally and distally, then in those situations you can use a augment plate, or you can augment the fixation with a screw or a cerclage wire. Even rotated fragment will heal fractures extending in the junction where stability in the shorter fragment is doubtful. Always augment these junctional fracture with a additional plate. More than a centimeter separation of the reverse fragment from the nail, the one has to, it has a poor prognosis, and these are the ones which you have to observe serially when they come for follow-up. Thank you very much.
Thank you, Sangeet. Any questions?
I have a question that, Sangeet, could you find out that depending on the location of that reverse fragment, whether it is anteromedial or posteromedial or anterolateral, posterolateral, the things have some common observation, or it is irrespective of the position of the fragment?
Sir, the femur is surrounded by muscles. So it is not specific that you will have a type of butterfly fragment which will reverse or which will rotate by, say, 90 degrees or 180 degrees if it is anteriorly, anteromedially, or posteriorly. But usually these, you have to follow the muscle attachment. And why did you ask the question, sir? Is there any significance as far as...
My question is that, we know that, yes, femur is completely surrounded by good muscular vascularity. But as we know in tibia, we think of on the posterior side, it is a good site where there is a good vascularity. Meanwhile, in femur, have you observed that on this side of fragment, they take longer time to heal rather than on this side of, like, on the adductor region, where there is a good muscles, or sometimes on the lateral side, we have vastus lateralis, but sometimes in posterolateral side, we have little less. So have you observed anything, or is there any thought?
There are two observations. One is the size of the fragment. 8 millimeters or equal to or more than that. They have higher 8 centimeters, sorry. So more than 8 centimeter fragment, they have a higher chances of a delayed healing. Second, if the contact of the butterfly is not there at one of the ends, or it is separated beyond a centimeter, these are the ones which are likely to head for a non-union. But again, and third factor is the age. And fourth is how well fitting your nail is in the medullary canal. That means working length.
Sangeet, I have a question. How do you kind of like assess your length when you have these fractures? Because if you look at some of them, like, your butterfly kind of like crosses your fracture ends. So some of those might be a little short. So like we used to do it closed as well before. But like nowadays, like whenever I have a segmental combination with huge big butterflies, or when there is no cortical contact at all, I kind of like tend to open and just go back to the butterfly, keep it there, don't wire or something, just as a measure of getting my length right, and then nail them. So any observations on that?
Most of them I do on a fracture table. So what I do is I ensure and check both the lesser trochanter, and I try to get them in one view. And the second is the distal, that means the knee joint. So in one shoot, or even if you adjust the height of the C-arm, you cannot see the complete both the knees. So even if you see part of the medial joint line, then probably you get an idea whether you are shortening or you are at the level or you have lengthened. That is the only thing.
Your rotation as well, because like I've said, like if you can get that butterfly locked in, that I know that my rotation is right, my length is right, so I don't have to kind of struggle. So that is one reason why in recent times, like maybe last couple of years, like we go after this open, don't dissect too much, but like get some small clamps and then get my butterfly, reduce the bigger one, and then nail them.
Yeah, that is the problem. even if we check the lesser trochanter and the patella, overlap of the patella in the notch, still there may be an error of malrotation at the end.
So with that, I think we move on to the
Can I
next.
comment, Doctor?
Yeah, please, sir.
Then-
Please, sir.
I think there is a very scanty literature available on these butterfly fragments, but the recommendations are, I agree with Gawhale that more than 1 centimeter of the gap, more than 2.5 then it is better to do, as Gawascar is saying, that you do open reduction. In recent times, I'm doing more open reduction than I used to do, because if you see the failure pattern, the patients who have the gap and the nail breaks and you have more failure pattern. Rather than the nail which has been such leg wire or the fragment has put in back, because the union is faster. He has shown the cases the union was for two years. It took 2 years. In 2 years, a lot of implant fail, I'm afraid.
Any comments from Tanna, sir? So, sir, your philosophies? I think we can move on to next lecture. Gadegone, sir, you have already shared the screen. Please go ahead.
So, thank you, Chandak sir, for giving me a very difficult topic. That is perineal, especially perineal femoral fractures. So, good evening, everybody. So, with the increased use of retrograde and antegrade nails, this treatment for long bone fracture, there is increased use, and that is the most important treatment nowadays for diaphyseal and proximal and distal femoral fractures. So fracture proximal or distal to long or short nails are not rare. However, lack of literature on this subject, no treatment guideline, and few cases had been reported in literature. So definition of a peri-implant femoral fracture is a conceptually defined as a femoral fracture in the presence of a pre-existing non-prosthetic implant. Therefore, a peri-implant femoral fracture and a periprosthetic fracture are completely different entities which should be assessed separately. Exact incidence is not known. The incidence reported in recent literature is 1.7 to 2.6%. Secondary fracture around a femoral nail is one of the most significant healing complications. The challenging factor is original implant, whether to retain or remove when you get a peri-implant fracture. And there is another challenging factor is the associated osteoporosis, screw holes, weakness area, bridging or overlap implant, position of a peri-implant fracture, and healing status of a original fracture. So broadly divided into two fracture patterns, the fracture at the tip of the implant or nail, you can say, because we are basically now discussing only the perineal fracture, and distal to the implant where the fracture has healed or not, that we'll see. So that Chan has classified the fracture type 1 at the tip and type 2 at the distal end. And he has also mentioned A, B, C, whether the fracture is healed, not healed, or healing. Similar type of a classification is also described by Virgilius classification system, and that is the same as you get the Chan's classification with little modification, whether the pattern of the fracture is included. So the two Italian Association of Orthopedic Surgeons, not only the proximal or distal to the tip, but you must also assess the classification proposal and the factor to be considered in classification: fracture localization, fracture morphology, fracture fragmentation, and healing status of the previous fracture. So this is one of the first example, a unstable fracture neck femur note a tight proximal canal in a dwarf female. And you can see this is the treated by PFN nail. And you on the closer observation will find that the fracture localization around the nail near the keyfell screw. There is a secondary fracture during the nailing has occurred. So 16.5 mm PFN nail being wedged into the narrow femoral canal to get next screw into the center of the femoral head, leading to the iatrogenic fracture of the anterior part of the proximal femur. So when the nail is not progressing with each blow of hammer, consider nail or canal mismatch. A cephalomedullary nail have expanded proximal part 16.5 to 70 mm reamer to be used its full extent, especially if the proximal canal is tight before you put the nail. So subsequent follow-up, this is the fragment, butterfly fragment, and the fracture healed without any problem. Another example, a fracture shaft of the femur at the junctional zone with patella fracture in a 32-year-old male treated by close interlock nail. Ultimately, after 3 months of surgery while driving two-wheel scooter, he had a fracture propagation, localization of fracture around the nail of the distal screw. And you can see here, it's a comminuted fracture extending into the supracondylar area. In such a situation, then locking plate is applied after removal of the lower bolts and bone grafting was done. 6-month follow-up, the fracture has healed. So such type of a perinealar fracture through the screw holes with the excessive trauma or stress at the fracture site before healing, you may get a fracture. Another example, 80-year female with a A2 type of a fracture suitable to be treated by PFN. And you can see it's a very thin lateral wall and a dwarf lady. And you can see here X-ray after 2 weeks revealed a complete spiral fracture localization around the distal screws and near the tip of the nail because of the mismatch of the canal and probably weakening of the shaft through the screw holes. So probable cause is stress riser during internal fixation, nail curvature mismatch. Any drill hole up to 20% of the bone's diameter will weaken bone by 40. 90 of the fracture around fixation implant occur through 90% of the fracture they occurs around the drill holes, and this is already published in 1994. So treatment options in this case, this is how it is. There is a stress fracture through the screw holes, maybe a mismatch, and it's such a fragmented fracture. Patient was reoperated with the removal of the implant and reassurance of the long PFN, and the patient has uneventful healing. Another example, a fracture after a short nail, you will find there the majority is seen on the WhatsApp group. We will get a stress fracture at the tip of the nail. Whatever the implant you use, whether you use a 2-screw system, single screw system, or even a anatomical nail. A press fit implant, larger diameter of the nail as compared with the medullary canal, weakening of the femoral cortex via distal locking, as you can see here, and stress concentration at the tip of the nail, localization of the fracture, majority of the time at the tip. And this is an example, a stress riser during internal fixation, fracture tend to occur at the end of the implant. Mostly it is a spiral fracture, removal of the nail, revised with a long PFN, and patient had a uneventful union. So the 240 or 250 mm nail crosses the mid diaphysis where angulation is maximum, and you can see here angulation is maximum, and therefore it touches to the shaft, and tight canal will produce a stress riser where you can see impingement by the tip of the nail against the anterior cortex of the femur. In excessively bowed femur in a low ladies is a very common finding which you see, and therefore This type of a design requires a long PFN, or you can use a short PFN, which is 18 centimeters, so that 24 centimeter nail or 25 centimeter nail will give a impingement effect. So early nail design were straight, newer design match shape of the femur with a slight mismatch. Even this also, there is some mismatch do occur even after a anatomical nails. So this is an example of a mismatch between the radius of curvature of the nail and the bone when long nail is used in elderly patient. And you can see here, there is a anterior cortex impingement at the supracondylar level, and there is also some mismatch at the fracture site, which has led to the mal rotation at the proximal fragment. So these are the stress points, and these are the stress points for the suprapatellar nail, or we can say a distal femoral nail also. And this is for the antegrade nail. Approximately 3 centimeters of the femur length distal to the antegrade nail, and about 5 centimeters retrograde nail being unprotected and coupled with osteoporosis is the predisposing cause for a stress point and leading to the fracture in antegrade nail and the retrograde nail at the tip of the nail. Example, you can see here a left femur subtrochanteric fracture treated by long PFN, showing the fracture at the distal tip. You can see here status healed fracture, and then ultimately, because the subtrochanteric fracture healed, it has been removed, and removal of the nail and locking plate surgery was done. So message in an elderly patient with a subtrochanteric fracture neck of the femur when using a long nail, please check lateral view of a distal femur under IIT if the nail is not progressing as expected in a soft white canal. As further hammer blows can shatter the anterior cortex of the femur. So this is an example. A 43-year male sustained this fracture, short nail. You can see her fracture healed, I think so. And then ultimately what has happened, again, and they fell down from the scooter, sustained a perinealar fracture through the empty hole and a spiral fracture extending into the trochanter. And this is in the substance of the nail, this fracture is there. So torsional load consequently led to the spiral fracture around the nail. And you can see it is mimicking the Vancouver B3 type of a fracture. So ultimately, this was treated by a long PFN with the circlage wire. Post-surgery, after 2 years of follow-up, everything healed. Another example. So choice of implant, whether it is used a long or short, the evidence said that in the unstable trochanteric fracture and subtrochanteric fracture require a long PFN is the choice of implant rather than a short nail. This is an example again, unprotected distal femur in osteoporotic bone in a healed subtrochanteric fracture with a trivial fall. And you can see this is the unprotected area, spiral fracture, localization around the tip of the nail, and commonest fracture to occur in osteoporotic bone in a distal femur. So this is how it is revised with a locking distal femoral plate. Distal femoral complications following antegrade intramural placement is a very common finding, and this has to be dealt with. And if at all, if you want to use a nail, it should reach to the supracondylar area, and there should not be any bare bone like this. Otherwise, it will produce a stress fracture in an osteoporotic bone. This is an example. PFN surgery. This is the locking nail is done for the tibia, successful proximal femoral nailing and distal tibia nailing, fracture healed. And after 10 years of follow-up, you can see a fracture has occurred at the age of 75 supracondylar region. These are the common things which can happen here. And ultimately, this has been revised with the locking plate, keeping the nail in situ because it was difficult to remove. So these are the fracture, they come in the substance at the distal, at the tip, at the proximal. They are not very well described. in the literature, and this radiological and functional outcome of the same patient after 1 year follow-up. So peri-implant fracture proximal to a long retrograde femoral nail, low energy peritrochanteric fractures may happen in the presence of retrograde nail in the femur, fracture at the tip of the nail, and this is now recently described in the Journal of Orthopedics, Trauma and Rehabilitation. So if you get a retrograde nail, probably the treatment is very easy. You have to exchange the nail with the long nail, or you can use an additional plate or a condylar blade plate. So this is an example, a distal femoral junctional comminuted fracture treated by a multi-lock supracondylar femoral nail. And you can see ultimately after 3 months of follow-up, stress fracture at the screw hole, no signs of healing, and locking bolt here you can see here. So these are the things which you can see in supracondylar fracture. These are new cases are coming up, and this is the complication not very well described in the literature. So nail in situ and revise with the condylar blade plate, and I am waiting for the results. Another example, you can see a peri-implant fracture proximal to a long retrograde femoral nail, unlocked nail. There is an empty hole of the screw at tensile stresses. Ultimately, the fracture has occurred, maybe a typical fracture, and around the nail, near the tip of the nail. And this is taken from the Journal of Orthopedic Trauma and Rehabilitation, just to show that the fracture after a retrograde nailing can occur at the screw hole junction if they are kept empty, or if they are locked, you can get at the tip at the intertrochanteric level. Ultimately, the author has revised with the condylar blade plate, keeping the nail in situ and aligning the fragment. Another example, a resultant forces and compressive stress are much more at the subtrochanteric level, you can see here. This is another case which I operated, a supracondylar. This is the fracture, and you can see here supracondylar fracture is was treated by this distal femoral nail, and then a condylar blade plate for the fracture neck of the femur. Ultimately, this has given way, and you can see here how the compressive forces and stresses work at the subtrochanteric level. And this is another stress fracture you can see here. So this is a new complications are coming up, whether they are because of the stress or because of the atypicality of the subtrochanteric region, very difficult to say. Another example, fracture at the proximal end of the retrograde femoral nail, because this is all a bare area, unprotected area, stress area, and fracture neck of the femur or intertrochanteric fractures are common, but they are very easy to tackle. Just additional plate may be required. So radiograph taken after 3 year post-fixation, fracture has healed. Another example, this is at the tip, an intertrochanteric unstable fracture, and you can see peri-implant IT fracture after a retrograde nail, and ultimately it was treated with the condylar blade plate, and the fracture has healed. So the Vergili's classification system and chance classification system did not consider fracture proximal and distal to standard centromedullary IM nail, fracture proximal to the IM nail, whether fracture united, fracture non-united, fracture during the surgery or after the healing of fracture at proximal or distal. So very sparse literature is available. When you use a centromedullary nail, only it is available for a distal femoral nail and proximal femoral nail. So I will show you an example. This is the fracture treated by nail, and this was the non-united, ultimately treated by exchange nail, fracture united, and after 5 years of follow-up, this patient got a fracture neck of the femur. So this is removal of the nail and abduction osteotomy, and after 2 years of follow-up, the fracture has completely healed. But if the fracture has not healed in the shaft of the femur, then the treatment becomes most complicated in such a situation. Another example you can see here, this is a non-united fracture and there is a fracture which is non-united, but the bone as well as the nail has broken through the interlocking screw away from a non-united fragment, and this is the fracture taken from one of my colleagues from the Lata Mangeshkar, and you can see here how this fracture was treated by long PFN and bone grafting, and this is fracture has united. So, peri-implant fractures, rare complication after intramedullary fixation of trochanteric femoral fracture. Take-home messages. If the original fracture has healed and it is stable fixation can be achieved by nailing, the fracture should be treated by exchange nailing to a longer intramedullary nail. You can see here, short nail, there is a fracture. It has to be converted with a long PFN and the fracture probably will heal. Another, when the healing of the original fracture is uncertain in that case, if there is a fracture of the shaft or a subtrochanteric region or a intertrochanteric area, in that case, keep the nail in situ, remove the screw, and you can have an additional plate with or without bone grafting. So in conclusion, options after perineal fracture, proximal, distal, whether it is healing, non-healing, stable, unstable configuration, and depend on the fragmentation and implant in situ, our treatment revision plan will be different for each and every case, and there is no fixed protocol for the management of a perineal fracture. However, both revision surgery with exchange nailing and locking plate or adjoint locking plate osteosynthesis appear to be adequate treatment whether you keep the nail in situ or exchange it. Thank you very much. Thank you.
Thank you, Gadegone sir, for a wonderful composition and compilation of cases of peri-implant fracture, especially with the nail. Dr. Sanjeev Gaur wants to comment. Please, sir.
Gadegone sir, what is the role of short nail PFN? Do we still, because generally you do a short PFN, introchanteric fracture, but having seen so many complications you have shown of a nail tip fracture, should we abandon it or use a long anatomical nail, or people still use the short nail? I'm slightly confused.
Recent literature says that the unstable trochanteric fracture and a subtrochanteric fracture preferred implant is a long PFN. For a stable type A and A2 type of a fracture, even 18 centimeter length implant is sufficient, and there is anatomical as well as the comparative study has been done. Relatively stable fracture, they do well with the short as well as long. But 24 centimeter length in a dwarf lady should be abandoned and should not be used. Use 18 centimeter in a very proximal fracture, in a subtrochanteric level or a high subtrochanteric level. It is always better to use a long period.
Okay.
Jethwa sir, yes, please.
Yes, I have a little comment on the short PFN. If you try to superimpose short PFN on a bone model on lateral side, when you look at from the lateral side, it may be congruent with the little anterior bone. But what happens that some of the PFN where the screw is little posterolateral, it's fine. But some of them, the screw goes absolutely in a horizontal, or rather in a right angle to the nail. In those cases, what happens? We try to rotate PFN so as to get the screw in the center in the lateral view. Now, doing that, we are now not matching the intramedullary canal. So think of something is rotated maybe only 15 degrees, but it is not with the original human bone curvature. So probably we fail if we do not pick up the right kind of a design of a PFN. So there are chances that in lateral view, it looks very much jammed nail. But in anterior posterior view, you may feel like, okay, you can go, there is some space available. But in lateral view, no, it is touching the anterior cortex. So there is a design problem.
I totally agree with you, sir. Actually, PFN, whatever it may be, as Tanna sir said, it is a oversold implant. And I do agree that this is oversold implant. Complications are many, and there are so many problems with the PFN design, whether you use a single screw or double screw. Probably we need to think over as a trauma surgeon whether to use or you go by literature. Depends on your commitment. But I think I totally agree with Tanna sir that it is a oversold implant.
Thank heaven Dr. Shiva is not here. Otherwise, he'll be back.
Thank you, Gadegone sir. And now we have a lecture from Dr. Tanna sir on junctional distal femur fracture, how to achieve a stable fixation.
My slide.
Yes, they are visible, sir. And you can be heard.
Junctional fractures. The problem of the junctional fractures are when there is a transverse fracture proximally, it's difficult to really reduce. As you can see, this is externally rotated, this is flexed. So to reduce this fragment, you got to need all the things which is required. Easiest will be an open reduction, but this can be managed, even the closed reduction, if you have the know-how. First and foremost, externally rotated fragment is internally rotated with a sand spin. Find out an entry into the piriform fossa, because I feel all proximal femur fractures should have a piriform fossa point of entry. So you have it in AP and a lateral view, piriform fossa entry. And this is flexed. So your K-wire, your guide wire will have to go into the flex position of the fragment so that you enter the medullary cavity. Now, having entered the medullary cavity, now you can take a control of the proximal fragment. So now you ream it. Once you have reamed it, you introduce this device into the proximal part. And having put the device into the proximal part, with this F tool, you will be able to get the reduction. And once you get the reduction with the F tool and with the help of this closed reduction, you will be able to achieve. Once you get the closed reduction, guide wire passes through. And this F tool is very important and is very useful for such situations. Once the guide wire passes through reamer and a nail, and you will be able to get the good fixation. Still, you see here, there is a small opening here. Probably here, the point of entry should have been a little more medially than this point of entry. This will not happen. Anyway, it held up very well into 9 months' time. And this is the one. Transverse fracture is hardly ever a problem except a reduction. Now you can see here, this is the thin nail in a wide medullary cavity in the proximal femur fracture. It's not that good for the nail. There is a very thin nail, even proximally it doesn't have much hold, and even distally it doesn't have much hold. So this thin nail, which is like this, it will give rise to the movement and you will always get the instability there. So thinner the nail, particularly when it is not having any hold onto any of the fragment, is not a good situation. Now this oblique, this butterfly fragment or this fragment, they need to be made one piece. This is years back we used to do this, where it was a cerclage, some screws I have put in, and at the end of 6 months, with the nail it is held up. Today we all know very well, the cerclage is easily available. So this fracture on a fracture table, you can reduce it, or even without the fracture table, you reduce it. Put a cerclage. Once you put in a cerclage, it becomes a one piece completely. So transverse fracture and a spiral fracture, well treated by nailing, as the construct is stable. May not need cerclage as adjuvant, must be done for a better healing as bone continuity is established. And this bound fragments together can now sustain the forces of the muscle. But this femoral artery which is passing by, you got to be careful before you do the cerclage and you take up the cerclage. I'll come to that a little later. Such oblique fracture or a slightly spiral fractures, they are better treated with the cerclage and the nail. Then I think the healing is hardly ever an issue and you will be able to get the things going perfectly well. this sort of a fracture, when you do the cerclage, it becomes one stable construct. Once you've done the cerclage, it's a stable construct. Whether you do the cerclage by closed methods or by an open method, depending upon what is available to you. This sort of a fracture, no cerclage was used, and you can see the proximal hold is very poor. And there is hardly any is only borne a position which is also not very good. And this piece is there. That's the reason this went into non-union. But almost a similar fracture. You do a cerclage, you get one piece reconstructed. And even if you do open reduction and do the cerclage, I don't think it is any sin at all. So why not do a reduction cerclage and get early certain union? So these short oblique fractures or a spiral fracture, they are ideally treated with cerclage. But if you do the cerclage and you end up into cerclage like this is from the Google, you end up into cerclage like this, then it's not good enough. So don't hesitate. If you have to go down and open it up, you open it up. Now, if you ended up with this, I feel there is no point in just leaving that. In these situations, I would go ahead and put an adjuvant plate. These are the ones where you see the femoral artery. It's very safe to do at this level and this level. But if you go more proximally, the chances of femoral artery getting affected are comparatively more, or if you go more distally. So that's the reason why you have to be careful when you're doing this cerclage by the new AO method, which is there. Today, I recommend all subtrochanteric fractures which are comminuted like this are not necessarily stable with nailing alone. I strongly suggest they be treated with the nail and adjuvant plate or a cerclage. This may be an overkill, but we are taking a human being and he or she has to have her own life. So overkill is not a sin. I feel overkill is a must in orthopedics. This sort of a fracture in an elderly person, cerclage is done, and this till after the cerclage also I felt it's not stable enough. So I went ahead and did the hook plate, and the patient is walking about in 5 weeks' time. You can see very well. Such a comminuted fracture, when you do the nail, even if you do cerclage, it is not going to be that stable. So this ended up into a non-union, and then ultimately it had to be treated with the adjuvant plate. I feel on day one, if you get a situation like this, don't hesitate. Put an adjuvant plate, it's not sin, and then you will not be able to have a situation where it goes into non-union, patient goes on for 4 months, 6 months, again comes back either with a broken nail or with a non-union, and then you will have to do it at the second stage. And as you can see, that all this breaks down because of the situations which is unstable. Now this subtrochanteric fracture, this is the commonest occurrence occurring. As you can see, the subtrochanteric fracture proximally, where is the hold? Surgeon has done this. Proximally, there is hardly any hold. There is one screw which is from the thing that is not really holding it. And so that's the reason why there is a good hold lower down, but proximally there is no hold. Such situation, what's the use of treating this fracture, subtrochanteric, which is very, very notorious for non-union. Or you can see this fracture. Only this proximal JG2LT screw is there. Even if there was a screw which was going here, this is a very unstable construct. So ultimately, 5 years, 8 years, 9 years, this went into non-union and carried on like this. So this is the reason I feel when there is no hold onto this, on day one, in a plate, you will not regret at all. All these are the ones which you see as subtrochanteric fractures. Even if you put a cerclage, if the hold is not very good, there's not going to really hold on. So go ahead and put in a plate. There is no harm in doing this. All this is the one which is occurring. As you can see here, when you rimmed it, the big rim is there, you've done the nailing, and this is the one proximally is not having a good hold. The subtrochanteric fracture is very, very notorious. You see here, this is the one which is comminuted and the nailing has been done. This is very unstable. It goes on and on and on, and ultimately it had to an adjuvant plate, and the thing ultimately held up. And as you can see, in 4 years' time, everything is held up. But you see, this is day one. This is day one. Where is the hold in the proximal fragment? You put one or two screws, it doesn't give you the hole. Even if you put in a screw here, it doesn't give you the hole, which is going to be that good with this sort of a proximal piece. So in this sort of a situation, day one, I'll augment this with the plate and may or may not graft. Mostly there will be no grafting over here, but I'll augment the plate, which I feel is absolutely necessary in this proximal fracture. Comminuted junctional fracture are unstable only in nailing. So more non-union chances. So overkill, put in an adjuvant plate and you will not have a regret. This fracture, I put in adjuvant plate, patient walks about almost immediately and there is no problem with that, the fracture heals up. Now, this is a very common sight. When this piece is a long piece there, you pass a screw and this always breaks down. Once it breaks down, the construct is very poor. This breaks down here, you put in there, and this is the reason the nail breaks down. This is a very poor construct. So there is no point in that. And you can see this can be very well treated with the adjuvant plate, and then the fracture heals up with a superb stability. So why not any doubt on day one do this? When I saw this case in a meeting, some commented it could have held up only with positive reduction PFM. This is an overkill. I'll agree. But when you're doing a second or a third surgery, can you take any chances? Overkill is only for half an hour of surgery and patient has no time constraint during surgery. So I feel every human being has to have a chance of first operation healing. And even if that is an overkill, I don't think there is any harm. Why should there be no overkill in first surgery? He spends 4 to 5 months and the money and in the first surgery. And if the second surgery is to be done, it is 6 to 8 months. It passes by before the second surgery is done. So he will be away for about 8 months, 9 months or a year. So in orthopedics, I feel it's a really big, heavy price to give. So overkill is not a sin. And all these things is done, it doesn't harm the patient at all. All this nailing which is there in proximal femur, you can see there is a wide canal or this, all this is the one which is never going to heal up. On day one, you put an adjuvant plate. This is the best chance for this junctional fracture to heal up. All this is the fracture. Either you can do a cerclage. I have no objection against cerclage. You can do a cerclage or you do an adjuvant plate. This is for the non-union. So it was an adjuvant plate was done. But on day one, I would have felt this would be very, very amenable to a cerclage. And all these are the fractures which in a non-union, we always treat with the plate and the graft. So this is the one which all of us have been treating this and we know very well how beautifully it heals up. Now, only observation is when you put a nail and you put a plate, the healing takes a long time. Radiological healing takes a long time. But the patient walks about and move about without any pain. He goes on coming with the x-rays. 3 months it has to still not heal up. And probably it takes 6-8 months for a good callus formation and the completed healing which we see here, it takes a longer time to heal up. And if you put in a plate, don't put a small piddly little plate like this. This is not going to be effective. This is too short a plate and it's not going to be functional. Now I come to the junctional fractures of upper 2/3 and the lower 1/3. This is the one which is the bugbear. I feel this is the one which is the commonest non-union we see in the shaft femur is this junctional fracture. And this junctional fracture when we see with the non-union, 14 months non-union, it so beautifully heals up with the adjuvant plate and the medial graft. So this is the one which I feel that if you're treating it with the adjuvant plate and the medial graft for a non-union, why should you wait for the non-union to occur? This is a very poor construct, as we all know very well. Again, this is the fracture, non-union, we treat it like this and it becomes all right. You see the fracture, 1.5 years, went into this non-union, walked after 24 months. She was an orthopedic surgeon's wife, so obviously treated by the best of the surgeons in the city. But you can see this. This is so very unstable construct that it is floating. You can see my slide?
No, sir, your slides are not moving.
But Now you can see the slide, the previous slide which I moved.
No, it is the same one with a long plate, which you talked, I think, before about 2-3 minutes.
Wife. This is orthopedic surgeon's wife.
No, no. Mm. The slides are not moving.
So the slide with a nail and a long plate is seen, sir, with two broken.
Which is the slide you are seeing?
Patient's name is Pranjal Kothari.
Long plate. Pranjal Kothari. I'll stop share and I'll come back.
Yes.
Now you can see my slide.
Yes, sir.
Okay.
Beyond this.
एक्स्ट्रा कंस्ट्रक्शन है अब तो वो इतने साल से रहेगा ना तो कहना हमें तो एडवांटेज मिलेगा ना इतने पुराने हम
Slide 40.
Yeah. Are you seeing the slide?
Yes.
Now we can see. Yes.
Now, this is an orthopedic surgeon's wife. As I mentioned, she walked after 24 months. Now here you can see distal femur. The hold in the lower end is very, very poor. There's the reason this is swaying and there is a lysis which is there. So distal femur, I feel, is the one which is very, very notorious. You can see again a distal femur, non-union. This is the one which you can see the typical non-union distal femur. You see the CT scan. You see the nail is floating in the distal end. It has a decent hold up more, but there is a floating in the distal end. And this nail which is floating in the distal end, this is typical of a junctional fracture. Today I feel the junctional fracture, the option in a transverse fracture like this is a distal femur nail and not an antegrade nail. Some surgeons talk about antegrade nail with 4 screws or 5 screws is going to be as good, but I think I am not convinced about it. This either a distal femur nail, which is there, and then you can see the whole thing is held up. You can see after distal femur nail, there is no instability at all, and that's the reason nothing was done. If I had found some instability, I would have added up a plate onto this. Some surgeons talk about this sort of a distal proximal femur nail, antegrade nail with so many screws around is a better option. Somehow I am not very convinced about it. Now here it is. This was a fracture, again a junctional fracture. He has an osteoarthritis knee, so I didn't want to do a distal femur nail. I did an antegrade nail, put in an adjuvant plate, and the patient walks about on day 1. And over the time, the fracture is completely held up. And this is what I feel is the one which is ideal. As you can see here, even 3 screws. Again, it has gone in for a non-union. The people talk about if there's a multi-directional screws, then it will not heal up. Then it will not go into non-union. But I feel it's not 100% sure. So I feel such a fracture, when it doesn't heal up, it needs an adjuvant plate and an anterior bone grafting. You do a medial bone grafting. You do a lateral bone grafting is not going to be good enough. And then ultimately heals up with this whole medullary cavity DSW. And when I talk about anterior bone grafting, I go around here. You see the line of weight bearing is always passing on the medial side in this side of the femur. It comes over here. So this is the one where I go around, I make in a cut, I do the shingling anteriorly, anterior medial and posterior medial, and I put in a graft there, and then the plate is put subcutaneously. This is the way I do it. Few people feel that antegrade nail will multi-axial, multi-screws in distal end. If antegrade, it may be better option. I don't think it is all the time it is true. All such fractures, ultimately, when it doesn't heal up, needs a grade. Now, here was the fracture treated by a joint replacement surgeon. When he got a fracture, he gave this nail, which is a very poor construct here, as you can see. So naturally, they expected it had to go in for non-union. This is the stage I came. I treated with the plate and the anterior and the medial bone graft. It healed up. But this, if the surgeon was aware, it could have healed up very well with his nail and an adjuvant plate. Things would have become all right. So I feel there should not be any hesitation in doing a day one adjuvant plate. I am convinced somehow that for a distal femur junctional fracture, safest thing is a nail and an adjuvant plate. There should be no chances taken. This is the best way. You can see here 4 screws distally till it has gone into non-union. So that is the reason why you don't have to think about it. Osteoporotic fractures. If you put in this osteoporotic, even the thickest nail which was passed, there is no hole distally, no hole proximally. It has to have an adjuvant plate all the time. So these junctional fractures, I feel, more so in the distal part and the comminuted fracture in the proximal part, they should have an adjuvant plate. It's an overkill, but I feel it is a must. Upper junctional fracture, transverse fracture, or stabilized anatomically with closed or open circlage is a better option. If comminuted and in doubt, adjuvant plate is a must. Lower junctional fracture, distal femur nail, and if needed, a plate is a must. I will take all all the time. Thank you very much.
Thank you very much, sir, for wonderful advices on junctional fracture and going almost for a overkill to fix them with rotational control it as well. Any questions to Tanna?
Yes, sir.
Yes.
Sir, I just want to ask that we have now for encirclage multiple things available. So in all your experience, SS wires versus cable versus fiber wire versus fiber tap. So anything we can learn that which is the better or which is the selective for which type of encirclage?
Honestly, Jawahar, except for the circlage, which is just normal wire, I have no other experience.
Anyone who has used other things? Jawahar Jethwa, sir, you have
Yes,
used?
I have used fiber tap.
You are ultimately a mechanical reconstruction of the anatomy.
No, only yet.
Why it does it matter? I do not know.
So what is very important with the fiber tap is there is an instrument available which can tighten up to 100 kg and 150 kg. So that instrument, we have some loose type of instrument where we do not know how far we have tightened it. But with the fiber tap, the company is providing such instrument where you know very well that it is enough tighten. Otherwise, there is no specific advantage. And one more thing which I just want to discuss is that I had a discussion with the companies who are manufacturing knee joint implant. And I have just discussed with them that why don't you provide 2-3 holes in the femoral component where we can put a plate and fix it with the component so that in future if there is a periprosthetic fracture, then we can use that holes to fix up the lateral plate. I don't know, it was just a discussion with the manufacturer.
See, on an international level to do this,
Yes.
quite a lot of demanding proposition. Probably locally, we ask a manufacturer, he may give you that. But then there will be an objection whether it will make it loose, whether it will get a fracture from that hole.
Multiple.
And internationally, you won't be able to convince people.
Gaur, sir, you wanted to comment and then
Chandak, sir.
Yeah.
yeah, Gaur, sir first, then Naveen, and then Gadegone, sir. Please.
Tanna, sir, the role of augmentation plating is well established now in non-union. Now, I don't think it's overkill, but what are the specific indication you would use it primarily?
primarily today, I think in a junctional fracture lower down, where the medullary cavity is expanding, I would strongly suggest nail and a plate on day one treatment. And in a comminuted fracture, on the junctional fracture with the upper part, comminuted fracture, I will feel again primarily on day one, nail and a plate. If it is stabilized with the circlage wire, then the comminuted fracture, I feel that is strongly indicated.
Thank you.
Dr. Naveen, you wanted to comment?
Yeah,
please.
yeah. For circlage wire, I think that it is a good tool for the reduction, but giving the stability with the circlage wire is a problem. It get loosened later on. Any circlage thing get loosened up. So it is a good tool for the reduction while you are making the stability and alignment of the fracture. And the second question to Dr. Tanna sir is, what is your take on the length of the plate when you are doing augmentation of the plate? Many times, even if we put a short plate, it works in a certain area. But in certain area, when a osteoporotic, we have to put a very long plate.
I think 8-hole plate, 2 screws above and 2 screws below is as good. But
Yes.
shorter plate, I'm not very comfortable about.
Dr.
Yes.
Gadegone, your comments on this?
Yes,
Sir,
sir.
about that tape, which tighten the screw the circlage which we put in, we don't really tighten it to make it ischemic.
Yes.
Not really. It is ultimately it is an only reduction tool. The circlage is only used as a reduction tool and not for a firm opposition from bone to bone. So I don't know whether the tap will give you ischemia there when you tighten it that much. I have no idea.
With this, we move on to the next lecture, and I invite Dr. Vivek Trikha sir to carry on his lecture on ipsilateral femoral shaft and neck. Would be very interesting to know about concepts on femur and shaft femur.
Okay, so I'll be talking on the ipsilateral neck femur and shaft femur fractures. As was said, it's a topic which we all have different ideas and different over our own preferences. So let's discuss what can we do. The learning objectives of this talk are going to be understand the fracture morphology of these fractures, which may involve the proximal hip rather than the neck in specific. Describe the various ways which are there to manage this fracture and learn how to achieve good outcomes based on evidence in the world as well as our own practices which we are following. It's a challenging fracture. 10% of all femur fractures involve the neck femur or the proximal hip. Young adult males are common. One thing to note is that the shaft fracture is comminuted in the middle or third of the diaphysis, whereas the neck fractures are basicervical, usually vertically oriented. If you look at their Powell's angle, they will be more than 100 degrees if you really want to go and calculate. But the better part is that most of them are non-displaced, and really many a times you nearly have to look for them while dealing with them. The problems with these fractures is that 75 to 100% of them will have a multisystemic injury. Most of them are in polytrauma situations or multiple fractured areas. And the other thing to note for us as orthopedic surgeons is that nearly 20 to 40% of the patients will have some sort of knee injuries along with this, be it a patellar fracture, tibial spines, proximal tibia or something. And you can look at the cases which I'll be showing. Many of them are having some sort of a fracture in the knee as well, which we have been seeing in our own cases. The various things to consider in an ipsilateral neck and shaft fractures is how to diagnose them, timing of surgery, whether you use a single or a dual implant, how to do the sequencing of fixation, and what are the outcomes available. And these are the things which we'll be discussing over the next 10 minutes. Remember, whenever we are dealing with such fractures, neck fractures are missed in nearly 20% of the shaft fracture cases even now, with all our modern gadgetries. This is a paper which we published last year regarding the ipsilateral femur neck and shaft fractures of around 50 odd cases. And what we found was that even in our best of the centers, 6% of neck femur fractures were missed in shaft femur fractures when we had a low threshold of getting a CT scan. And CT scan is available at the drop of hat in my hospital. I'll just give you some examples. Now, this is a fracture or a pelvis fracture X-ray. This is the X-ray in detail regarding the neck part. And if you look at detail, maybe you might have a look at that. In retrospect, we found out that there is a hairline fracture, which you can see vertically. I'm just trying to show you and highlight that out here. And once this goes in for fixation with the standard anti-grade generation 1 nail, you have problems of a neck femur fracture. If you look at the CT scan in them and you are looking at the CT scan, it has to be 1 or 2 millimeter cuts. You will find that there is a complete fracture line in the axial scan, both in the anterior to the posterior cortex. In our paper, this is again a thing which we showed. A fracture of the shaft of femur was fixed, and in between it was found that there is a neck femur fracture, which had to be subsequently refixed with screws which was put in additionally from the same nail and additionally besides the Missa-nail technique, and had to be reduced. I'll show you another case. Looks like to be a shaft femur fracture, distal third. The X-rays of the pelvis as have to be done have been done. They look normal. Oops. And it was routinely fixed in our emergency in our hospital. And when my resident showed me this X-ray, we said, why did you fix the neck? And cephalomedullary thing was put. And he said he found a fracture inside in the neck femur while he was putting in this. And luckily for us, he had a cephalomedullary nail which was put and Cyrus sort of a nail, because of which we were able to put in the neck fractures. So we went back and tried to see what was the thing. And we had a CT because many of these were polytrauma cases, and in our hospital, the CT scans are many a times done for the abdomen part. And if you really look at these cuts, remember the cuts was done for the spine fracture. He had a spine fracture lower third of the L4, L3 region, for which this cut of the CT scan was done. And if you see, this cut was not involving the hips. It was just involving the abdomen and the spine region in this cut. And so we didn't have any sagittal or coronal sections for the hip. We just had axial sections. And then if you really look at the axial sections, you can find one fracture line going from front to back. So what we need to understand is that on retrospect, we were able to get an X-ray or a fracture line, a hairline fracture, which sometimes gets missed in spite of getting a CT scan. You just see a buckling of the posterior cortex of the neck in 1 or 2 cuts, and the rest of the cuts look to be normal. And then you are in for a surprise. This was fixed as was done by a thing, and later on you can see that it was an undisplaced fracture, went on to unite, and the distal shaft also united. So what in our hospital, in our series, with the best of CT scans also available, you can see only the fracture line in 1 or 2 cuts, and even it is shown in the world literature that you can miss a neck femur fracture. You need to have a proper hip X-ray and internal rotation, and get a CT scan of that area at 1 or 2 mm to really look for neck femur in cases which are high velocity cases, and you have a higher decrease or increase in suspicion rates for these fractures. So what do we need to do? We need to have an X-ray protocol of getting an internal rotation radiograph. Threshold for CT should be less, and look out for a fracture which is undisplaced. Always and always evaluate under fluoroscopy during and at the conclusion of fixation of a femoral shaft fracture, which many a times we miss. Rotations and radiographs, if possible, in 10 to 15 degrees of rotation. But remember that in spite of that, we might still miss a fracture of around 3 to 5% in the world literature is still there. In spite of getting all these things done, we might miss a neck femur fracture. Then when do we fix this surgery, and when do we fix these fractures? It's based on the high velocity and the ISS injury severity score, stabilize the life-threatening injuries first, and then you try to fix them as early as possible. Remember, they are very high and most of them are polytrauma patients. So maybe immediately you may not be able to fix. And sometimes the damage control orthopedics also needs to be applied in view of his abdominal or other injuries. Prompt, but not an emergent surgery is usually done when there is a polytraumatized situation. Now coming to the sequence of fixation, neck or the intertrochanteric region, or the shaft first. It is controversial. It totally depends from many surgeons' preferences and the choices. And what I'm going to show you is our preference in our hospital, which we have published also, and depends on the fracture pattern and displacement of neck femur or the IT for us. If we look at these fractures, there are two types of fractures which are along with combination with shaft fractures. One of them are the IT fractures, intertrochanterics, which are there along with the shaft. And the second one are the neck fractures. The neck fractures are usually basicervical. Very rarely they are subcapital fractures. So remember that these are the fractures. For the IT fractures, since your single implant and the fractures are in the same plane, it's most of the time we advise and we usually put in a single implant for an intertrochanteric with a neck femur, with a shaft fracture, because the fixation of one, which is antegrade nail, can have an impact on both the fracture patterns. Whereas when the neck femur is there, which is away from the shaft and the medullary cavity, you can have the choice of a dual implant right in the beginning, because the impact or the fixation of the neck femur may be totally separate and will not be influenced by fixation of your femur shaft. So remember this, then many a times in intertrocs, you use a single implant, but in a displaced neck femur, you might have to use dual implants. Let me show you one of the cases of this. This is an intertrochanteric fracture. You can say the trochanter is involved with the shaft femur, and the X-rays you can see of the pelvis also showing the same. Look at the patient. He was a 145 kilo BMI 40 patient having a neck femur or a shaft femur fracture with a distal third femur. We went about doing it the same way as I do all my cases. And what we found out, when we had to have difficult problems fixing on a fracture table, but here it's the surgeon's preference. What do you want to do? The way you have done before, that's what you are going to do. I'll show you his example to know and tell you how to reduce these fractures. So the first thing to ensure is that your middle fragment is got externally rotated. So until unless you de-rotate your middle fragment, be it for a neck or an intertrochanteric, you are not going to get the proper rotations issue. So we put in a shank spin in the middle fragment. Then also, because of this sort of an epsilon sort, or you can say a similar sort of a fracture of the intertroch, we were not able to get the reduction problem. So another K-wire or a big 2.5 Steinman pin was put into the neck fragment to get both of them in the third view, which you can see to get the reduction properly by derotating them and getting the varus and the valgus alignment proper. And once we were able to do this, we fired in 2 mm, 2.5 mm K wires, holding the shaft, the middle fragment with the neck fracture, while reducing and keeping them reduced in a minimally open position. Once we have been able to fix it with 3 or 4 wires holding the neck or the intertrochanteric region properly, we then put in and started making our entry point at the medial part in the various ways which normally we do. And then the standard nailing procedure was done. Once we had put in the nails, the intertrochanteric region was fixed, and subsequently the distal fixation was also done with the 3 screws in different planes. The problem which we encountered here was that to make our entry point more medial, it had to be close to the body. And once we had to put in from there, it was a huge incision just to put in a jig down, because unless we go from the superior part, all the incision had to be made was for the jig to go down right up to the tip. And ultimately we did his fixation like this. Got an X-ray, not the best of the reductions, but we assumed that it's an intertrochanteric, and we were happy with this reduction at his age and his body weight. And this is at 4 months that he was having fully united, 5 months, and he's back to his work. And thankfully, he has reduced 15 kilos of his weight by now. on our constant prodding performance. But remember that that's how you need to reduce your fracture, be it an intertrochanteric or a neck femur. Derotate the middle fragment, try to reduce the proximal fragment of the neck or the shaft, and then do whichever way you want to. So for us, if it is a neck femur or a fracture which is undisplaced neck femur, we normally tend to use a single implant and fix the shaft and neck simultaneously by putting in some preventive KYS before and then making our entry point. We hold the neck with KYS, make our entry point for the shaft, and use the recon or a cephalomedullary nail, which is ideal for such cases. Here again, you can see some examples of neck femur fractures with shaft femur fractures fixed with a single implant. All these fractures have been fixed with this sort of different implants. You can fix it with any of the cephalomedullary single screw. You can fix it with double screws. You can fix it with PFNs, the old PFNs, or you can fix it even with cases of lag screws which are there, or you can also fix them with intertans if you really require. So all these fractures which I have showed you have been relatively mildly displaced or undisplaced neck femur fractures. When we can be reduced on a fracture table, reduce and put in the preventive KYS for the neck properly first, and use a single implant for such fractures for the fixation. If the neck femur is displaced, or the fractures are widely displaced, there is comminution, and most of them, since being at basicervical region, your CC screws may not be able to help off your cephalomedullary nails or without an isolated also. Then the fixation sequence or usage of dual implants is normally preferred, but the fixation of sequence, whether to fix the neck first or the shaft, is purely as per surgeon's preference. We normally, implant choice is based on the fracture pattern, the comminution, and the bone quality. And as I said, since it is a basicervical fracture, we tend to use the DHSs more commonly than the CC screws with the neck retrograde nails which are there. So my take will be a displaced neck femur, subcapital or basicervical. We look at the neck femur fracture. We use a DHS with a retrograde nail or a CC screw with a retrograde nail, depending upon where the neck femur fracture is all about. We normally use a dual implant if it is a direct reduction or an indirect reduction, which we have to do or open up the fracture. And these are the various papers which are there in the world, which also have shown similar results with usage of whichever implant which we can. You can use a single construct or you can use a dual construct. And as I said, this is what we practice in our practice, that if it is an undisplaced or a basicervical fractures or intertroch, we use a single implant. If it is displaced basicervical, we use DHSs. If it is displaced with neck femur subcapital, we use CC screws with retrograde nail most of the time, but things can vary. Remember, the literature says combination of implants is usually advocated for a displaced neck femur fracture. 722 cases out of 65 studies, no clear superior implant choice. Both results, even in our study, the results and the union rates were same, though we had around 75% cases which were done with dual implants and 30% cases were done with a single implant. Neck femurs usually dual implants and intertrochs usually with single. Functional outcomes are good. But remember that the series are very small and good retrospective, most of the world literature which is there. One thing to note in outcomes of neck femur fractures is that there is a delayed or a non-union of the shaft fracture more, which is up to 20 to 25%. Dr. Sangeet was also saying, and normally shaft femur diaphyseal fractures have roughly a non-union rate of roughly 2 to 3%. Majority of them, 98% of them roughly unite. But when you have an ipsilateral neck femur and a shaft femur, nearly 20% of the fracture shafts may not unite because the majority of damage and the forces have been there on the shaft. And neck is usually because of the abduction of the position of the femur or the hip while the forces are being propagated after the shaft femur fracture has happened. And that's why you have a vertical fracture and mostly the basicervical fractures when this fracture happens. The neck femur has a low non-union rate of nearly 5 to 7%, as compared to a 20 to 25% in a normal isolated neck femur fractures. Isolated neck femur has around 15 to 20% fracture non-unions, whereas here it is less, but the shaft is nearly 20 to 25% fractures. So that's what we need to take care of. And this was there even in our paper, where nearly 22% patients had delayed union of the fracture shaft femur, for which other procedures were also required in few cases. I'll just show you a few examples. This is a polytrauma case, and most of them are polytrauma. Bilateral lower limb fractures. Right side was a shaft femur with a segmental tibia, and the left side was a neck femur with a segmental shaft femur with a shaft tibia with an open wound. And this was the open wound on the posterior aspect of one of the legs. So how do we plan and what to do first? All the things which we have talked about may not work here, because here the patient is a polytrauma patient and you need to many a times do the damage control orthopedics here. And what we were able to do in the first sitting was to manage those conditions as much as possible. So we fixed some of the fractures on the left side. If you see, the right side was put on a fixator, and the left side, we put in for the segmental femur, a retrograde nail, leaving the neck femur, which was intertrochanteric, away right now. We did not fix the intertroch femur on the left side right now, because we wanted to fix the lower limbs as much as possible based on the damage control. One side we nailed the segmental part of the femur and the tibia, and the right side we did with the fixator. The right side, as you see, we had fixed in with a segmental tibia, and the femur were put in on a fixator. Once we were able to stabilize, you can see this is how the clinical condition of that patient was. And once the patient went into ICU and stabilized, then we reduced the neck femur fracture on the side of the segmental femur subsequently, and changed the X-fix of the right side to the nails, like this. 4 years later, you can see that she has got the union part. The segmental fracture of the femur, along with neck intertrochanteric femur, which was there, fixed with dual implants, has now fully united. And the left leg gave us some issues, but it also later on improved with dynamizations and fibular osteotomies. And this is her complete picture after 5 years of follow-up, with the neck femur fixed, the segmental femur fixed on the same side, and subsequently the opposite side as well. So here, the patient's life took priority, and we had to change our sequencing of fixation to make sure that the physiology does not deteriorate further, and the neck or the intertroch part could be managed later. So life first, then stage fixation, and proper initial assessment is particularly important. Another case, basicervical. See, most of these fractures are basicervical. See the patella, which is broken out here. And here we fixed the same way as a retrograde or a dual implant fixation. But here we went about fixing the neck femur first to reduce it properly. And the same procedure was followed. We put in a shank spin to derotate the middle fragment, opened up the thing to put in our homens, put in our K-wires and the guide wires in the central position in the lateral view, opening up, reducing the femur or the neck femur part for a DHS in a standard way, and fixing it with 2-hole DHS with a derotation screw, which was done for this fracture. And once this was done, then we went about fixing the distal fracture, which was there by a retrograde femur nail. But the problem which many a times happens with this is you cannot many a times decide your nail size, which should be overlapping, and you need to be very accurate here many a times, which is more easier once you do a DFN, and then you can choose your DHS long barrel plate as per the length of your your DFN, and you can overlap them to avoid stress risers or PIFFs, as Dr. Gadegone had shown. So this was the way you can see that this fracture was fixed. One of the screws of our DHS, which was a locking screw, was impeding upon our distal femur nail, and we could not have shortened the nail, because if we had shortened, there would have been a stress riser in between them. So we put in as close to it as possible. Later on, we had to dynamize and remove that screw, and we fixed in and removed the dynamization, removed the nail as well. And subsequently, you can see that the femur shaft, the neck femur had united. The femur shaft also has united, though not looking properly out here. But finally, if you see, all the fractures have united, though it required the dynamization because the length of the nail and the overlapping of DHS was slightly an issue. Once you fix the intertrochanteric or the neck femur first, and then do your DFN in the second manner. Whereas in the first case, which I showed you, we fixed the DFN first, and then we went about fixing the leg femur with the DHS later, which is much more easier for us, I think, than doing this way. Another case of polytrauma who had polytraumatic abdomen situations, you can again see the patella, which is comminuted in the proximal bone. All these fractures were having some of the knee issues. Embolization for the spleen was done, which was damaged, and the same procedure was done here with the DHS with the derotation along with the DFN, which was done. So here, once you, normally what we do is we fix in a DFN first, keep the length of that DFN around 5 centimeters below the lesser trochanter, so that we can use a DHS around 3 to 4 hole DHS, which will overlap this DFN if we are going in for a dual implant. The patella at that time was not fixed properly, and we had a lot of issues with this patella and the distal fragment of the femur, which was causing a lot of delayed union. You can see all these X-rays are at the same time, but the femur neck has united properly, but the shaft was still into a delayed union, which required some PRP injections and subsequently went on for union. And finally, remember that many of these cases go in for non-unions and give you a lot of trouble. Like this case, which was managed somewhere else, which was bad, horribly went wrong for the neck femur or the intertroch part, as well as for the shaft femur part, which subsequently we had to change in both the fractures with the retrograde nail for the shaft and a valgus osteotomy for the neck part. Remember, the shaft femur still didn't unite in spite of our nailing, which was done. We had to do another case for some procedure for him after 1 year. We removed the angle blade plate. You can see the valgization is adequate. The patient is still fine, but I can tell you his shaft femur still shows the same gap. It is around 5 to 7 years now, but the patient is having no trouble. But the X-rays still do not show me complete union of the shaft femur. You can still see these X-rays are now latest. Some of the X-rays show that it still may not be united, though it is around 7 to 8 years post-operatively without any problem for the patient. So the message out here is choose a surgical plan that optimizes the anatomical reduction and adequate stabilization of the neck fracture. That is paramount for you. For the shaft, we need to restore the length, alignment, and rotation of the femoral shaft fractures. Remember that reduction and stability of the neck femur in displaced neck femur I'm talking of. In undisplaced, it's usually uniting. But in displaced neck femur, it is more important than the number of implants we are fixing. And hence, we normally tend to go in for a dual implant if the neck femur is requiring much more attention than the shaft femur for us. Remember, shaft femur out here is going to give you problems. It is nearly 20% failure rate of delayed or non-union in such cases, whereas the neck femur usually unites faster. Thank you for your patient hearing.
So can I ask a question, Dr. Trikha?
Sure, sir.
It is well established that in ipsilateral scenario, the neck femur has less non-union rate and the shaft femur has a more non-union rate. And this is also with the segmental shaft femur also. The lower fracture has higher non-union. What is the reason according to you? It's not understood apart from the high energy trauma.
Yes, I fully agree with what you are saying, because we are seeing fracture shaft femurs which are very high velocity, be it segmental or isolation when the neck femurs are not there. But they do not go into non-union to that great an extent. The problem for me maybe is that we concentrate more on the neck femur part than the shaft femur part, which we feel is not that important because of our regular practice, where now roughly 3% or 2% of our shaft femurs ever fail or go into delayed or non-unions. Whereas what we need to understand out here is that this injury has been caused because of the hip inflection, knee inflection, the entire forces going on to the shaft, which are not breaking after the neck or the patella, they break the shaft, distal third, more comminution. Mechanism is so high. And then as a corollary or later on, because of the abduction of the hip, the neck femur breaks in vertical fashion. So because of our general tendency and our normal practice in day-to-day orthopedics, we tend to give the neck femur more importance, though it certainly deserves that importance when it is a displaced neck femur. But we do not give adequate importance to the shaft, which it requires. And we normally tend to go in with what I feel many a times is we tend to go in with a slightly under-reamed nail most of the times, or we are not giving the adequate fixation to that part proximally, or provide more instability than what can be given in such cases. And that's what leads to more failures for the shaft femur in combination with the mechanism and the soft tissue damage, which is already present and is not under our control. That's what I feel.
So,
Okay.
Dr. Vivek, I have a small thought. That
Sure.
is very well you have explained that one should check the neck region before you close because you are going to miss. So my thought is that can we minimize these incidences of missing the neck fracture by simple clinical examination? If there is an anterior tenderness or if there is a tenderness of the bitrochanteric test, so anything has been thought of or detailed in any of the publications that it can be minimized by a clinical examination?
I've gone through the entire world literature for this fracture when we were making our paper also last year, which was published. Because I was surprised that I thought we were doing a great job with our CT scans and getting all the investigations in our hospital without any money for the patient. And we found that in spite of getting CT scans done with 1 millimeter cuts, we were missing out on some fractures. And we retrospectively went and looked about it. There are world literature still says that in the best centers of America, be it with Paul Tonetta or with other people, they still miss out on 5% of fractures. They do get a scout CT done for the hip region in most of your high velocity trauma of the shaft femurs. And they have not been able to come out with a solution for this because the pain is such that you cannot pinpoint the pain to bitrochanteric test or any of those tests. However, Corey Collins' paper from America has given us the so-called overkill of Dr. Tanna, which is there, that you use a cephalomedullary nail in all high-energy shaft femur fractures. Why do you want to use a nail which is leaving the neck femur away, which subsequently within a week or sometimes which is an undisplaced fracture may develop a fracture which is bicortical and subsequently come up within a week or 10 days. So there was only one paper from Corey Collins, which is saying that in his practice, what they have started doing is that for every shaft femur fracture, which is a high velocity fracture, they are fixing the neck as instead of the two horizontal screws of the locking, they are all putting them into the neck because even if there is an I showed you my 2 CT scans and those were retrospective observations, which we also could not find out until unless we looked at the X-ray intraoperatively and the CT correlations to see that this was a fracture which was there only in 1 or 2 millimeters. To obviate all those issues, they say, why not just simply put in the 2 screws in the neck so that you can go about it. That's the safest way out.
Yes.
Yes.
And then Naveen.
We have, yeah.
And
Okay,
Sangeet, you wanted
Sangeet.
to say something?
Yeah. The reason why they are missed out is usually these patients, they have polytrauma. They are other injuries like chest injury, head injury, abdominal injuries, and the priority is to that. And they are in ICU, critical care, and as a part of routine X-ray, since there is a deformity, only shaft X-rays are taken. And the neck part are most often undisplaced, as Dr. Vivek also pointed out. And that is the reason you will not elicit any tenderness in the situation. Second thing is this neck femur behaves differently from a normal neck femur, where the non-union rate is almost 25 to 30%. We don't have so much non-union when we have a ipsilateral shaft and neck. And also, you pointed out, like if it is a car seat injury, the impact is first the shaft, where it is a high velocity injury, and then it is transferred on the neck. And it is also interesting if the patient is sitting in adduction or abduction.
Acetabulum comes.
Exactly. The next is the acetabulum,
Yes.
central fracture dislocation. So these are what is published in the literature.
Yeah, Naveen, please go ahead.
What Dr. Gore said is why there is a more percentage of non-union of the soft femur. The commonest mistake we make when you use a single implant, to get the valgus in the neck femur, we do a over-traction. And then we forget to release the traction before locking the distal screws. So many times it remains slightly distracted because we have done an over-traction and we are fed up with the long surgery. And the second thing is many times these fractures are infraisthemal. From the primary, it was requiring some augmentation plate from the very beginning because we cannot have two screws above and two screws below in a single direction where we get a rotational stability. So it is again an invisible instability which we are noticing on that day because we are fed up with the long procedure. And the third thing, what Dr. Vivek told, since last 15 years, we have not done routine femur nail. We are doing neck elements and the nail because that is the safest way.
Vivek sir, may I ask you one question? Is
Yes,
there a relation of a blood supply with the distal femoral fracture with ipsilateral neck and shaft? Because most of the perforators, they go in proximal 2/3 of the femur. And relatively, distal femur is a relatively bare area with a lack of blood supply. No, it is relatively as compared to the proximal femur. Is there any correlation with the distal femoral non-union in a floating fragments? It's a floating fragment. You can say the blood supply from the proximal has cut off, from the distal has cut off, so that the middle fragment, it's an isolated intercalary fragment. So what is your take on this?
There are not any evidence or literature at present. I wouldn't say evidence, but literature on this aspect of having a disturbed or vascular supply for the middle fragment. But certainly, as we are looking at in the isolated shaft femur fractures also, the junctional fractures and the distal fractures which are there, which are most commonly the fracture patterns which we observe in neck femur or intertrochanteric with shaft femur fractures, is nearly on the distal third fracture and the upper 2/3 distal 1/3 junction. We just now heard Dr. Tanna also showing that the junctional fractures are the ones which are going in for non-unions or delayed unions with our standard nailing system and the mechanisms, and they require much more stability as per his experience, because the biology is still maybe precarious, but the stability is more required, which takes more time to throw callus, and the unions are happening in delayed fashion. And when we are having a dual fracture in the same limb or the same segment, we are already compromising, as Dr. Thakkar was saying, on the fixation of these fractures by either using a smaller nail or not fixing them properly in the proximal fragment, because we need to fix the dual segment as well with the DHS or some other fracture or some other implant. And the distal part is also not so greatly fixed in proper ways, in the multidirectional ways. So I feel that it is both a combination of a decreased vascularity, which is already present in all the fractures of the distal third femur, shaft fractures, which is junctional fractures. Along with that, the notional less stable implants, which we use for the shaft femur here, vis-a-vis more concentration for the neck femur that we do in such cases, which both of them combine together to give us these non-union rates, which are pretty high. If you really look at it, in a diaphyseal fracture, to have a 20% failure rate nobody is going to use that implant if we really look at it in an isolated shaft fractures. But still we are going on and thinking that it is part of the job or something like that. We nearly need to concentrate on fixing the femur properly, or maybe augmentation of that, as was shown by Dr. Tanna and other people as well, who are using it for an isolated junctional fracture of the femur as well. And I've done that in non-unions of these fractures. And I've put in an augmentation plate along with a valgus osteotomy, and they unite within 3 months. That's what I've seen.
With this,
So
we
the
want to-
stability is under our control, and we
Yes.
should use that, our ability to give the stability. Biology is not in our
Not in-
surgeon's hand. So biology
Very
can
true.
be taken care of after 6 weeks or 3 weeks or 8 weeks if it's not uniting.
So thank
Very
you,
true.
sir, for your excellent presentation. And now move on to a next topic of Dr. Jawahar Jethwa's topic on medullary fixation. Happy fixation, what he says, elastic fixation is a happy fixation.
Thank you. Thank you very much for this opportunity. Basically, I am going to talk more about the shaft femoral fracture on a couple of the slides for the proximal femur. But before I start, let me give one more hint that if you are able to ask the patient to do internal rotation on the next day, there are chances that you might pick up that you have missed neck fracture, because he will not be able to do active internal rotation after the shaft fracture femur. So now let me start with this. So I'm going to talk about titanium nails, stainless steel elastic nail, and also ender nails, and some points on maximum curvature point and ender nailing for the shaft femur, which is also in a various conditions is possible. Some case-based messages, some technical aspects of modified ender nailing, and also some part of the final locking nails and all those things. So let me start with that ender nail is a stronger than titanium nail elastic nails, particularly for the pediatric, because often we are not satisfied with the elastic nail because it becomes a little bit more weaker. And these are the cases where I have just found out a couple of the images from internet that it may go for an angulation after fixation. During fixation, it was not there. So in any younger children, there is no problem, but for the older children, you can go with a post-fixation angulation if they are elastic nail, which are very thin. So what we can do is that we can think of a stainless steel nail. So these papers says that there is a complication where it is 4 times higher in titanium elastic compared to stainless steel elastic. And this is very important that we should know that up to 35% complication is there versus only 16%. And that is something very important for us to know. But so when you go with a ender nail, which is much stiffer, then the chances of this post-fixation angulations are less. So whenever possible, it is good to use these things, and you can avoid angulation because they are much stiffer and much stronger. And this is the way we can get a good function and without any post-fixation angulation. And there are a couple of other papers which say that the tan and stainless steel elastic nails, there is no difference. The only difference is this 1/3 cost. Another says similarly, the overall trend is in favor of stainless steel elastic nail, especially being cheaper than tan nails. And the another paper says that tan nails and SS nails are equally effective. So why not to use something which is less costly, that is stainless steel nail. About the maximum curvature, we all know that we have been trained that let us try to put that maximum curvature, or we can say spindle or whatever, at the fracture site. But what happens when you see multiple cases which have been healed on internet, and we can see that it may not match the maximum curvature, but still it goes with a good amount of healing. So curvature is not in our control. So better we use a good implant and good stability, and we may not be able to do that. This is a simple thought which is in my mind, that on one side we are talking about a maximum fixation at the fracture side. On the other side, we say that to boost union, we must avoid rigid fixation near the fracture side. So both of things are probably, particularly in an older age I mean, older pediatric age, like more than 10 years or 12 years or 14 years, this may be the thing which you can thought of. Now, let me go to some of the conditions with nail. It's a good implant for polio patients where you have a very good fixation by the nail for the shaft femur fractures, especially for the upper third or lower third where you are not able to prepare, they put the apex exactly at the flexure side, then stiffer nails are better. And these are the other cases where you can see that you can get a good fixation in a length unstable fractures. So when you are using in a pediatric, when the dense medullary bone stock is there, it plays a major role and you will be able to prevent a further shortening because it is in a pediatric age of group, the dense medulla is going to hold these nails very well. So in pediatric femoral shaft fractures, subtrochanteric fracture, elastic nail is very well accepted. Multiple literatures are there. I don't know what happens on the 18th birthday and why we think now from 12 midnight you are not fit for undernailings or elastic nailings. So something which we have to think of the difference between published science and the practice science, and we have to think and consider, and we have to overcome some of the indicated cases where you can use the routine implants and also the elastic nails. So point is that in all these cases, you can use in an adult also elastic nails like under nails for the fractured femur. And especially in a polytrauma where you have a problem of embolism, where you don't want to pressurize the medullary canal with a reamer and with the interlocking nail, there you can do with this elastic nails and you can get a beautiful reduction, beautiful union in time without any complications. And there are a couple of cases where there could be a axially, length unstable fractures like this. But if the patient is relatively young and the medulla is very dense, you can go with nail and you can get a very good result with this type of Y configuration of such fractures where all these things come together and ultimately you get a full union with a good function, almost normal functions. One more point which I want to just say technically is that when you want to remove the nails, it may be nails or any other nails, you try to locate with the sharp instrument under IOATV in both the views, and then you can go and just make a gutter with some instruments. But thereafter, when you put a hook and when you are removing these nails, please put a betadine soft gauze piece, because these nails tend to have a good suction because of the vacuum inside, and then it will suck in the air. So there is a possibility of infection. Doing this, it will suck the antiseptic solution rather than. So nails is the aptly flexible, aptly stiff, adequate press fit force due to elastic recoil, long area of subcortical contact that also gives a no friction and better fixation, and can be pushed up to the bone surface, so you may not have a protruding, irritating ends like which is in a 10 nail. And it is easy to remove because there is an eye which you can use a hook and you can remove this. Very important discussion we had in the morning that there is a very high bow in an osteoporotic female 70. In all those cases, you can use nails because it accommodates whatever is the curvature at this age, and you can jolly well get a good contact on both sides, and you can get a good reduction. Regarding the fracture with a trachea, there is a possibility of passing nail by the side because femoral component is having an area on the medial side, also on the lateral side where you can negotiate it. This is one of the cases where there was a sharp fracture in the middle, and we have just passed this nails, and it has gone for a healing without any event, and we can keep the femoral, the TKR implants safe. There's another case which is my senior's mother who came across this subtrochanteric fracture with the same side TKR, where very carefully we can negotiate this nails and we can fix this fracture very well in a Y configuration, which is a modified undernailing, and there is a good amount of, there is a good union. Of course, there is little bit of going on the varus side, but when I calculate it is only 125, it was not exactly the varus. But at the end, what happens, if there are some problems, even there is some irritation at the end of the nail, when you remove it, still we can keep the TKR implants unhurt, and we can have finally the same movements and same functions of TKR as well as the fracture which has healed at the hip region, the proximal region. Sometimes we come across this problem, which is not a very, it is a lower third fracture, but still distal to this also, the same technique, which is called simultaneous medial and lateral insertion of the nails with two surgeons with two sets of instruments. So what happens in such cases, you can pass nails from both sides. And then the question of a distal canal, which is more roomy, does not happen because you are passing the nails from the side, which is having a subcortical sort of a fixation. And if you look at the end, uneventfully, this goes in a very good union with a good function. And so in such cases, what we do is that we have two sets of instruments. There are two surgeons, they're simultaneously passing, because in such cases, in a lower 1/3, if you try to pass one nail, then there is a natural translation of the fracture and you will not be able to pass the second nail. So bit by bit, just as a point we start, and then it can be done. So this is the a good method in a lower third diaphyseal fracture, not the metaphyseal fractures. This is another case which was like this, very heavy patient. At the time of injury, he was more than 110 kg. He is reduced, but then with this method, we could go away with a distal third fracture very well with foot function. Regarding double fracture, yes, you can use the same modality. You can fix the proximal fracture with a CC turbo screw as well as interfragmentary screw, and also in Y flexion, Y configuration, you can go with the ender nail, and both of that can be treated very well. Similarly, for the segmental fractures, you can use the elastic nail. Everything can be very well roped in, all the fragments, and it can be having a very good reduction in the fixation. Now, my point is regarding the understanding of anteversion and antetorsion. The first figure you can see there is no anteversion, no antetorsion. That means it is not a normal bone. Just for the sake of explanation, I have just drawn this thing. It is antetorsion when the lateral trochanter also is put posteriorly. Again, this is not normal human bone. The normal human bone is that the tip of the trochanter is lateral, but after the intertrochanteric line, pertrochanteric line, it goes anteriorly. So anteversion is a word which is specifically for the proximal part at the pertrochanteric line. Antetorsion is what we do when we rotate the implant and try to put into that. So in cases of a posterolateral slit, the problem is that if you try to avoid the posterolateral slit, you put an implant, it goes into the posterior part of the head, sometimes out of the head. So we need to have an implant like this, which is not possible. This is just, I have marked the particular picture, which is not possible to pass an angled DHS screw, or in that case for the PFN also we cannot have an angled screw. So for this reason, for anteversion, obviously it is not possible to bend the hip screw. These are the cases with the posterolateral slit which you have missed probably with not having a CT scan, where you can think of, rather than rotating and putting into that, there is a method where you can go with a CC screw, interference screw, which is in the anterior part, and thereafter all these very well contoured nails, and thereafter the turbo screw. So the questions of the lateral wall can be avoided once you can avoid the slit which is on the lateral side. And these are a couple of the things which are part of the modified nailing, where we can use this very well contoured nails and with the elastic hood clamp, and we can avoid such complications. And the methodology is like this, that you are putting a curved nail which which keeps or prevents the external rotation. And this modified nailing, the elements are like enhancing the press fit hold is by pushing this particular screw in between this particular nails. So it gives as a turbo, and it deviates the path of the nails inside the head, which increases the grip of that. So if I just give you this, a particular GIF which I have prepared, you can see that it touches the nails in AP and lateral view, and then it disturbs the path of the nail, by which the total grip inside the head and neck increases, and that's how we are getting this. Very important thing for the endonail is that these 5 very important contouring which we have to do, the sagittal two curvatures and the coronal another 3 curvatures. Each of them have their own roles to play, which I have explained very well in my YouTube video, but this is very important. And there could be any type of configurations like this. You can use the screw first, or the nail first, or the nails, or without any screw. All these things are the combinations and different variations depending on the fracture geometry. So even at the age of 74, you can do a next day walking if everything is very well planned, and if you can fix it and can reduce with this methodology of modified endonailing. Similarly, you need to employ all the smart techniques which all our stalwarts and all our seniors and other people like Dr. Shivashankar and so many have said that use your old methodology to get the reduction best. Thereafter, you can have your own choice of implants, but the reduction is very, very important that in all views, you try to get the best of reduction. So all modifications play a role, and when everything you do accordingly, you will have no knee complaint, no external rotation, very good fixation without any loss of reduction to the initial. In cases of a very high angle, like 140-degree angle, you might not get a good PFN at 145-degree. In those cases, you can use this modified endonailing where you will have a full recovery at 18 months, which I was just showing you in this particular case, where you can maintain similar to the opposite side, and patient will not have a limb length discrepancy. When you have an osteoporotic patients with so many different comorbidities, you can use this technique, get best of the reduction with multiple images which I'm showing, and also a clip at the distal end. And very important part is that all challenges can be overcome. And if you look at all these axes, there is no lateralization of the trochanter, and that also helps in an abductor force where patient is happy to get the reduction in a normal anatomical positions. Regarding the lateral combination, if such fractures are there, you try to push only on the medial side, and non-return axial push with musculo-fascio ligamentotaxis plays a role, and such fracture also can go with a good healing without loss of any reduction, and you can have a very good squat and smile at the end of 18 weeks. No proximal noil entry, no open reduction, no tension band wiring, no buttress plate, restored anatomy, and full great power at the end of the full healing. A very important point for the subtrochanteric fracture that no other implant can induce such a dynamic valgus force when you are passing the nails from the lateral condyle of the femur to the tip of the trochanter, which will prevent varus in due course of healing. So this is the method where you can use and you can prevent. Look at this very bad fracture, and at the end there is a happy fixation because of this modified. And this is another case where you can see reverse fracture, which is very stable, and this can also be very well treated with this method very simply. And in these cases, what happens is that as an effective implant, you are getting something like this. And that is the reason why there is a very good grip inside of the medullary cavity, which will not allow displacement of the fractures, and you can get away without any additional implants. The last slide is that there is a future. We are working on this, where we are thinking of putting a locking endonnail. So the eye is having a threads, and we can put a locking screw. We are not very much successful in this because making this eye is not that technically and mechanically possible. We are trying to see that if we can get a locking endonnail, but there are some of the cases where we have got a very good result. So I'm just showing one of them. So at the end, I just thank you And I just summarize that titanium nail may allow post-fixation angulation. So please be very careful in older age group. In addition to IT and subtrochanteric fracture, modified undernailing can be used for femoral staff fractures. And in selected cases, undernailing is a good option. Please consider this. And undernail removal is easier than 10 nails, particularly in pediatric case where you have no eye to catch all of it. So I thank you very much for this opportunity and allowing me to share my views. Thank you.
Thank you, Jethwa sir, for bringing out those advantages of Ender's nail, especially in the pediatric age group as well. Thank you so much. Any comments on Jethwa sir's presentation?
Jethwa sir, you are a master in this procedure, and I have listened to you number of times. Actually, there are some new things I can learn from your presentation. But I think this is one of the best method in the armamentarium of fracture fixation of the femoral shaft fractures. And I think this method should be popularized by you because you are giving lectures, you are also giving these practical tips also. But anyhow, this method in your state, it has been taken very well, but all over India, it is yet to be popularized. So I request you to make it more popular so that it becomes a minimally invasive, a happy fixation in majority of the fractures of the trochanter as well as the subtrochanter.
Yes, sir. Yes.
So with this, we'll go ahead with the Dr. Chandak sir and then Dr. Naveen Thakkar bhai.
Able to see my screen, sir?
Share screen, sir.
Yeah, I'm sharing the screen.
Yes.
You can see my screen, sir, now?
Yes, yes, yes. Go ahead.
So this I'll be keeping it very short and I'll make it mostly interactive. My topic given was centralization and prevention of malrotation during femoral nailing. There are 4 key steps in rotational alignment. Pre-draping assessment of internal rotation of the uninjured leg is very important. Keep patella central in AP and lesser trochanter. Note the profile of lesser trochanter. Note at the cortical diameters at the fracture site. And we have to replicate the internal rotation of other side. And in the distal interlock, when we do, we have to look at the perfect distal interlock with true lateral of knee. Pay attention to 4 important things: foot position, lesser trochanter, cortical width, and the fibular overlap. Of course, this starts with the fracture reduction itself, which is actually a prerequisite for rotation control. And fracture reduction in our day-to-day femoral nailing is a 4-step procedure. We also have to pay attention to all this. It was reported by these authors that malrotation is a very common after femoral nailing, and the exact definition of a malrotated femur is controversial, but it is widely agreed that a rotational malalignment less than 10 degrees is considered normal with a compatible normal function, while more than 30 degrees is a deformity which requires correction. Research-wise, determination can be done, but difficult in day-to-day practice. You can do it by a CT torsion measurement, but actually not carried out in day-to-day practice. The rotation control starts right from the prepping step. And if we are in theater at that moment itself, we can look at the patient position, patient's patella orientation, and the lesser trochanter and the foot plate. Because once you come after the draping and once the patient is draped, then it becomes a bit difficult. However, your palpatory skills are still valid. In lateral position, the entry point is easier, but increased positional difficulty and imaging difficulty is there, may lead to certain more amount of valgus and external rotation in this position. The table and the rotation, both are to be correlated. If you are using an eccentric post, it is a bit different. If you are using a banana position, it is a bit different. And if you are using a thigh support to elevate the knee to get a better imaging for locking distally, the position is a bit different. So reduction and alignment correlation also is to be done for taking into account the rotation of fractures. If you are using a clamp assisted reduction, that gives you a better ability to control rotation. Also, in lateral plane, a good imaging has to be there so that exactly you can correlate which way the rotations are going on. If the rotation is difficult, I use this thread tip pusher so that I can rotate the fragment as well as I can push it and then properly align the fragment. During guide wire selection, centering, reaming, and final fixation, we always keep an eye, and my right hand would always be on the patella of patient so that I know that the limb has not moved in between. And guide wire, not only medullary cannulation of guide wire, the position of guide wire is important, the fracture reduction is important, and the final guide wire, what position it takes is important, and we have certain tools to manage that. A correct distal reaming of the fragment which is well aligned and rotationally controlled is also important. So what I found out is a conventional reamer can reach the femur up to this point. I use an extra long, which is actually 580 mm custom made reamer to drill up to the last point. And here, rather than a corde bend reamer, the reamer is usually corde bend. I would use a straight reamer to go as distal to get a good interlock in a distally placed fracture. This is what I found interesting. When we pass a guide wire, usually it is gently C-curve and there is a corde bend. So first hit happens onto the lateral cortex. At this point, so what I would do, I would just rotate. Here is the femur which touches. So I will rotate 1/4 quarter outward. And then once it comes to this point, usually here it would be anteriorly placed and then one again quarter. So with 2.5 turns, most of the times we would be in the center of femur. However, you can adjust it seeing the C-arm. Coming to rotation judgment. So this is what I have found interesting, and I'm going to show what I have noted. This is imagine a left femur. So when you see this picture, so this is usually an externally rotated femur, and you see an external condensation. This is what you see is the internal condensation. So this is a normal femur configuration. Pay attention to the rotation of this is neutral. Here it is externally rotated. Here it is internally rotated. So this outer condensation in external rotation, the inner condensation is there in the internal rotation. And with this also I judge the rotations. This is very interesting to find and not reported in the literature. For segmental fracture, rotation judgment is difficult. So you have to manage both the reduction first and then only the rotational judgment would be fine. If you find the rotational alignment of both the fragment is different, you can rotate, negotiate your guide wire and rim, and after rimming you can adjust the alignment. The knee axis determination by corticord does not usually give the rotational guidelines. However, it gives you the axis determination. Rotation control in revision surgery on a routine table is easy and can be compared with the normal table. However, this usually is not possible in an acute trauma situation. In a revision situation, usually you will find the limb quite externally rotated. So you can put a bump and then internally rotate that, equalize on the both the rotation. And if you are open reducing, the linea aspera usually gives you a good rotational judgment. Say friends, we are very happy in rounds when the rotations are fine. But to achieve this, actually we have to act at the time of surgery itself. So 4 key steps in rotational alignment, again to emphasize, are mostly clinical judgments and radiographic C-arm judgments, and then we get the rotation right. Thank you so much for this opportunity. I must thank Dr. Trikha for giving me opportunity, and any questions if they are there. If not, then we can move on to the last lecture by Dr. Naveen Thakkar.
I just want to congratulate you. A superb observation you made for the condensation of the
Right.
And one more thing which I just want to point out is that please see that the fracture table foot piece is in the line with ankle. In your first slide, it is in the line with ankle. In your second slide, the foot piece in the middle. So when the foot is attached in the middle, when you rotate, it also adds onto the translation. You might get something wrong. A good fracture table is very important.
Can I say one thing?
Yes, sir.
Sir, you have shown that the bent guide wire, how to you are rotating. What we do is, once we pass the reamer across the fracture, we remove that guide wire and put another straight guide wire that will not deviate from the center.
Yes, a very good important tool. And therefore, on our trolley, we always keep two guide wire. One is
Yes.
constant, at the tip, it is bent. And
Once you reach to the distal fragment in the center with the reamer, we remove that wire which is going either anterior or posterior or lateral or medial. We change that wire, and that is protected by the reamer, so that will not deviate.
yes, absolutely right. A very good tip.
So the crux of lecture is constant attention to how to avoid the mal rotation and mal position of your guide wire, nail position, and everything. So this is a prime criteria that you should think of preventing the mal rotation, which is mostly iatrogenic.
Yes. It is just like driving on the highway. Straight.
So, thank you, Chandak sir. And now we will move to last lecture of Dr. Naveen Bhai on dynamization. What is the evidence?
Thank you, sir. Thank you very much for your kind invitation. And now we are going that there is a practical dilemma of the surgeon. He has done a femur interlock nailing. Fracture is not uniting. What is the role of dynamization and case-based, and what is the evidence in the literature? We'll be learning together. 90% gets united, soft femur, there is no problem. Only less than 10% has a non-union, and that typically is of supraisthemal and infraisthemal problem due to stability. You can see here, is it failing? Why? Because there is a isthemal combination, which we have already talked of junctional fracture. It's a supraisthemal fracture. Again, you require a good stability in this type of fracture. Again, infraisthemal, you know that you need a good stability. You have to add something in the stability. Only nailing will not work in this situation. You can do primarily, even a short plate will take care of 2 screws on either side. So main problem is the stability, bone-to-bone contact and the alignment, and the biology, that is vascularity, osteogenesis, and the envelope and the soft tissue. The stability is under our hand, alignment and adequate fixation. Biology, you have to fill the gap to induce the osteogenesis, respect the envelope, and the adjuvant therapy if it is required. That we know. But we are discussing today only dynamization. Does it help or does it harm? Let us see case by case. And what is the method of dynamization? What should be the timing of dynamization? What should be the type of fracture where dynamization will fail or succeed? So this is the case. 12 weeks. What will you do? Sir, can I ask the question to Dr. Jawahar Jethwa? Because I can see him only.
It seems that on the medial side, there is a good contact. On the lateral side, it is less. So 12 weeks is little bit, in a borderline. We may wait for another 1 month. I mean, this is around how many? 3 months.
The dynamization has to be done or not, Dr.
No,
Chandak?
no.
Chandak, sir?
Yeah.
Dynamization will help here or not?
So basically, patient has any pain or difficulty?
No, it is a slight pain, slight limp, and the X-ray is showing it is not uniting, and patient is moving one surgeon to other surgeon with the fracture line. Sir, ye jud nahi raha hai. What to do?
So what I would still hold on, because I can see good cortical continuity of the fracture. So I'll just keep on holding without dynamization at this point.
Okay. Gadegone, sir?
Okay. My take is, if this fixation is stable, then only the dynamization.
This is the static X-ray. We know only static X-ray. We are saying static. We do not have a dynamic study of stability or instability.
But here it looks that it's a stable implant. Probably removing 1 screw proximally may help in.
Okay, so you want to say that we will remove this screw proximally.
This one.
Okay, This one, proximal one. Okay. Surgeon did the same weeks. Surgeon got your advice and he has done the same thing. Now it is at 18 weeks. What will happen?
The callus and the union of the fracture is, relation is not a very good thing, and therefore this fracture will not heal. Actually,
Yes.
there is a ratio of the callus after dynamization and the fracture gap. If the callus
So you-
dynamization, there is some ratio is there. So there is the callus formation, very little callus formation. Probably it may not heal.
Yes. So
I think-
you say that the probably the decision was wrong. Dr. Gores is speaking. Who is
Yeah.
speaking?
Dr. Gaur. I think
Yeah, so-
at 18 weeks, if this is the picture, I'll do exchange nailing.
You do the exchange nailing. So the previous decision, we are focusing on dynamization, sir.
That was
Whether
not wrong.
the decision was taken was wrong.
No,
No,
decision was not
no.
wrong. Sometime it helps, sometime it may not help.
That is why we what is to be done? The audience is asking, the young orthopedic surgeons are asking. So this is the dilemma of every orthopedic surgeon, either senior or a junior orthopedic surgeon.
No, post-operatively, we have to see that has dynamization occurred, or it has stayed the same as it was before screw.
This is here. This is
So
the
here it has dynamization not occurred because it is snugly fit in the proximal part. So it will
is
not allow
snugly fit.
sliding of the screw.
It is not allowing. Okay.
Not allowing.
Okay.
Yes.
Okay. So these are the findings of all the experts, right? And you can see what happened. At 24 weeks, it is failing.
So it has become a more unstable construct by doing
Yes.
dynamization.
So many times dynamization does not help, it harms. That is the message. So what was wrong here? What was wrong? What was wrong with the dynamization technique? Can anybody say the principle of dynamization and what was wrong in this case? What was wrong here?
Actually, we have to see the excursion of the nail after dynamization here.
Yes.
Suppose if there is there any migration of the nail with the previous X-ray?
Any other finding by the expert?
So lower down, if you can see, there is some amount of rotation of the nail which is seen.
Yes,
And
that is there. That is there from the previous one.
So I think in that situation, the nail is not at all stable. We have to remove the nail and do a proper fixation.
That is right. That is right. But we are just focusing on dynamization just now. The principle is dynamization should not be done at the cost of the rotational stability. Dynamization not to be done at the cost of rotational stability. You cannot remove all the screws from one side. That is the principle. Right? This is the another example, 12 weeks. Both the screws are there here. And this is the position at 12 weeks. What will you do?
This is not going to unite by even dynamization, removing a single screw also. It's because there is there is no process of union at all. Dynamization to work in a stable implant, you must have a process of some bone formation.
Okay. So that is the opinion of Dr. Gadegone, the expert of nailing. Any other opinion from anybody? Chandak sir, what do you feel? What will happen? What will be the fate of this patient? Fate of this case? This is your case. Imagine that this is your case. At the 12 weeks, he is presenting to you and says that I have some limp and some pain, and it is 12 weeks. What will you suggest?
So I would not suggest him dynamization. If at all I want to revise this, I would go ahead with augmentation plate and addition of grafts in the defect. That would be my final solution to him, because
that is right. But one surgeon has advised him the dynamization.
I would not advise him dynamization.
Okay, let us see what is happening. Now we have discussed it. So it is a very confusing situation as far as dynamization is concerned. So we must keep our ideas clear-cut, concept clear-cut with the evidences. Now let us see what is happening. Surgeon removed one screw. This is 18 weeks. What do you feel? This screw has been removed. The upper dynamic hole is kept. The static hole has been removed at the 18 weeks. What do you feel now? This was at 12 weeks. This is at 18 weeks.
This is going for hypertrophic non-union.
This is going for hypertrophic non-union. Anybody has any opinion?
So as it looks, we can see some amount of trabecular crossing here. So I'm not
Right.
sure with this X-ray. I would like other two views to opine on this
Right.
case.
You're right. You're right. Absolutely. We need more planes of X-ray, epilateral oblique, right oblique, left oblique to see the circumference of the callus. You're right. But what will happen? What do you think? What will be the fate after dynamization? It will fail, it will harm, or it will useful? Any taker? Dr. Jawahar bhai?
How is the patient's feeling? Is the patient feeling that more pain, or he is feeling that yes,
No,
things are happening?
after dynamization, he is feeling better, little better.
So one thing is very clear, that dynamization means excursion of the nail. So most of the time when you remove one screw, let there be dynamization and put that screw back so that the rotational stability is not
Okay, so you are advising
compromised.
that now after 6 weeks, we have to again give the rotational stability by inserting the second screw which has been removed.
Yes, after dynamization is done.
Okay.
Yes.
Okay. Any other opinion? We are making interactive so that we can learn out of this. So see the thing is what is happening. We have to understand the nature. Screw retained at 24 weeks, it is healed. So the principle is you should not remove all screw from one side. That is the principle of dynamization. Dynamization has not to be done on the compromise of rotational stability. When you are having a little bit comminuted fracture or an oblique fracture, if it is a transverse fracture, yes, that we will come to know about the type of fracture. But the one principle is at least one screw has to be retained on either of the segment. And where you want a dynamization, it should be in the dynamic hole, and static has to be removed. This is the common principle. Another case, 20 weeks. This is the condition. What will you do, sir?
28 weeks.
28 weeks, proximal femur. This patient had a 5 to 6 fracture, ulna, radius, shoulder, multiple fractures in a polyclinic setup.
This is a comminuted fracture. This dynamization is not going to help. It will make a more unstable fracture. It needs bone augmentation by plate and bone graft.
Yes, you are right, sir. You are right. Perfectly right. You have said that at the cost of the stability, you cannot do dynamization. That is the principle.
So
And
although
here the surgeon has the dynamization by removing both the screws from the distal. And it was a supraestable fracture. And it is going for the non-union. We revised it with the nail and the plate. Now another case, 16 weeks, distal fracture. This is the position of fixation. And now the surgeon has removed both the screws from the proximal part, and screws started breaking, nail also started breaking. So it is creating an instability many times. So rotational stability is the priority rather than the dynamization. How much dynamization is possible? 15 mm is the total. So we can do this much of dynamization, not more than, and we have to minus the screw diameter. So 6 to 8 mm is the gap where we can do 6 to 8 mm dynamization, not more than that. So the principle, this is the paper, this is the evaluation of method and timing in nail dynamization for treating delayed healing femoral shaft fracture. Retained screws are better than all screws removed. More than 24 weeks, it is not effective. That is what the finding has been done by many papers. Another thing, more than 50% becomes unstable and fail. Significant shortening happens when there is a combination. So more than 50% fails on dynamization. Intramedullary nailing, femoral shaft fracture, transverse or short fracture ischemal fracture, type 1 or type 2 combination, there you can do dynamization easily without any problem, much problem. But this is the benchmark study where they have not done a single dynamization. Static fixation we use even in inherently stable type 1 and 2 fracture based on authors' previous investigations showing the loss of fixation in 10% of those receiving dynamic IM nailing. Healing occurred in 98% of the fractures treated with the static lock fixation. Average time to union was 19 weeks. What author has summarized? Static locking of intramedullary nails in a femoral shaft fracture does not appreciably inhibit the fracture healing. Routine conversion to dynamic fixation, although occasionally necessary, need not to be performed. If you do not do dynamization, there is not going to be any harm. But if you do a dynamization in certain condition, except these conditions, transverse or short oblique, ischemal, type 1 or type 2 combination, and the condition that not more than 24 weeks, then it may be effective. So this is the principle or the evidence with the dynamization. Another case, this is the 24 weeks. What do you think? "24 weeks.
Again, at 24 weeks, this will make it unstable.
It will make unstable, right? Absolutely right.
Although we are discussing dynamization, but my observation is that there are many cases which I have seen that there is no activity at all. Most probably they are smoking.
Yes, you are right. But here it was not smoking, it was a young girl. And this case came to us. When it came to us, and what we have done, that I am showing that stability part has to be taken care of. 28 weeks. This is the situation. And patient is doing window shopping. Every 4 weeks, X-rays are getting done. 32 weeks. Now what to do? The operating surgeon is trying to see every 4 weeks X-ray. And this is the every 4-week X-ray. You can see from the 24, 28, 32. Now it has come to you as a second surgeon. What will you do?
This needs augmentation by bone grafting or exchange nailing.
So dynamization will not help. As you see.
No dynamization will help.
I think now
Here the problem. Yes, sir.
I think this would proceed to auto dynamization and then healing.
So auto dynamization is a possibility of breaking the screws by the nature, you said.
Yeah, because as
I think there is a good alignment here, good contact here.
yes, so
Almost good contact.
this may heal.
This may heal, but it is taking longer time.
Yes.
So we are worried. Patient is worried. Surgeon is worried. Patient is moving one to other place. So we just injected the bone marrow. We thought that we have good stability, but we need some biology to be given. And you can see it has healed at 36 weeks. Started healing. And 40 weeks, it healed. So
But it is very difficult to say, Naveen bhai, it is because of bone marrow.
yes, you are right. You are absolutely right. So dynamization, if done wrongly, it would have surely failed. We do not know that injection has helped. But surely keeping the stability, according to that paper, wait, it may take time, but have a static locking. Don't go for dynamization in a slighted combination, this combination.
Naveen bhai, my one observation here, all nails are there trochanteric entry point with medialization in the distal femur.
Right.
Is there any different nail they are available, or it's something like, because all they are trochanteric entry point. They are all cetromedullary nail. But
yes, you are right. You are right. If the nail entry and alignment is little bit like that, then there won't be a collapse of the fracture in the shaft.
Yes.
That is preventing, not in the alignment, the medullary canal. So that is slightly preventing. There is obliquely locked fracture at the fracture, and that gap takes longer time to heal. So in this condition, you have to wait. While you are waiting, patient is very much worried. So you can add the bone marrow graft. And what are the conditions where you get a success? Defect is less than 5 mm. it must be a stable construct. This is the prerequisite. No signs of infection. As Dr. Jawahar Jethwa said, good number of progenitor cells, no smoking. And the smokers, this will not help. So these are the prerequisites before doing in such cases when there is a dilemma of to do a dynamization or not to do dynamization. So now another case, these are the slides from Dr. Tanna sir. Day 1 before dynamization, 3 months post-op dynamization, 7 months. So dynamization helps. And you can see here, the sir has shown beautifully at 1 year. Again, a case where there is a bone plug here. You can see here. If there is a bone plug, the dynamization will be difficult. It will not help much. There should not be a clear space below or up. You can see the nail has progressed up. Another case where there is a bone block here. So there is no place of nail to migrate to accommodate that collapse if fracture impacts after dynamization. Same here in tibia. If you have done this subchondral fixation in the femur or tibia, then also there is a problem. Fracture wants to heal. As Dr. Chandak sir has said, auto dynamization, screws will break. If it is not dynamized, it will break and it will get healed. So nature wants to heal and it gets healed gradually. 3 months after the screw breakage, you can see it is healed. Combinated fracture do not dynamize, but if not healing, graft it. It is better to have augment or graft it. Do not make the unstable it further. Here you can see that the surgeon has made the unstable. The nail has migrated. On one side, it is removed. So again, at the cost of rotational stability, do not dynamize. If you feel that with the one screw, dynamic screw, I can have a good rotational stability, then you can dynamize. Or you can do this grafting like this. Dynamization is not must for the healing. Fracture heals up without the dynamization. That the paper has said. But there should not be any obstruction in dynamization like here, screw or like this. Dr. Vivek Trikha saw us the case of the neck femur and the shaft, where the nail was abutting at the DHS screw and there was no collapse of the distal fracture. The similar case, there should not be any obstruction for migration of the nail. Otherwise, this gap will not close. So you have to remove this obstruction and then it will heal. Another thing is the bone plug here. It even of dynamize, it will not work. And the bone plug here, you can see here. When you are doing internal nailing, you may get the bone plug inside it and then it will not heal. Or you have a callus here, bone, extra bone, then also dynamization will not work. Nail has to have a space to migrate up or down after dynamization. At the time of index operation, keep nail short of subchondral bone in the mid shaft. So little short nail is better, little short. But dynamize before bone plug forms at the end of the nail. So always see before dynamization is there a space above or below, accordingly where you are dynamization. You must check for the space. There should be enough space. Another trick Dr. Tanna sir has expressed is a transverse fracture at isthmus. Ream more, 1 to 1.5 mm larger, adequate size nail, not canal stuffing, pushed by hand and not hammered except at the end. In dynamic mode, screw at one end in oval hole away from the fracture, but still it has to be rotational stability by at least one screw and the full weight bearing on day 1. Forget about the fracture will heal. So ream 430 nail and have a nail of 410, little shorter than what you have ream. Transverse fracture with good bone-to-bone reduction, there is no need to do static locking, only do dynamic locking. That is also allowed in the tibia and the femur. But even if you do not dynamize, it will heal. Same fracture converted to dynamic nail holes, then it is retained on the one side, one screw. So the principle is you have to retain. So the conclusion is dynamization is not a must for healing. If need, dynamization should be done early by 6 weeks when you see the callus. And you take the precaution that there is enough space and the rotational stability is not hampered. Nail must have a space to travel for dynamization. Isthmus fracture, where you feel that there is a good stability, as I have shown in that case of the bone marrow, it was an isthmus fracture. Dynamization can be done, but it is better to have a stability than dynamization. A small request to all. Now in today's EC, we have made that Aadhaar is mandatory for update. So update with the Aadhaar, all the members. And thank you very much, sir.
So Naveen bhai, excellent presentation. And I think Jethwa sir,
Yes, sir.
actually you can comment on the today's webinar. How it is.
It was very important and very clear-cut messages have been sent that in all aspect of a femoral nailing, as we are discussing our intricacy, that you have to be very careful to get the best of the reduction, best of the implant, and also good observation intraoperatively and also in follow-up that what is happening. So in my view, many of the important points have been emphasized, and many of the new tricks, many of the new practical tips which has come out, and this should be a very good reference for all those people who wants to find out that there could be minimum of the failure after femoral fractures. So many good tips are there. I'm really happy to know all this and also to be part of this webinar.
Chandak
So
sir, please conclude.
do not take the femur fracture lightly.
Chandak sir, please conclude.
Thank you all the faculty members for giving your valuable time and preparing so well for this important webinar. That was a wonderful meeting. I think we have all enjoyed and had a lot of take-home messages. Thank you, Dr. Gadegone sir, Dr. Trikha, for constituting the nails subcommittee. Opportunity to have a good introductory webinar on nailing, and now part 3 has intricacies of
comfort fabric conditioner का 48 challenge थी मतलब दुलाई के बाद एक ढक्कन comfort
Good night.
Thank you very much.
Thank you.
With this, we'll close this webinar, and thank you Ortho TV for giving us this wonderful platform of patient and our own education on this one.
Ortho TV and IOTV both, sir. It's a good symbiosis between the IOTV and Ortho TV.
Yeah. Thank you so much. Thank you, Naveen bhai, for giving that opportunity. Thank you so much.
Thank you, sir.
Maharshi, if you are there, we can just close down the recording and transmission.
व्यक्ती कॉल करीत आहात ते व्यक्ती उत्तर देत नाही.